morning. Can you hear me? Yes. Okay, good morning. My name is Silvia Restrepo. I'm the Vice Dean of Research and Creation of the University, and I wanted to welcome you today to this event. And this is your house, and of course, particularly with so close friends, institutional friends such Landy and Foundation Santo Domingo, who are friends and are here joining us during, and they were with us during this pandemic in such an spectacular way. And I also would like to say hello to the people that are connected. I guess we have 100 people already connected, and obviously to the people here in the forum. And when you offer these hybrid events, the people are going to say, oh, I mean, downtown, Bogota downtown, and the Bogota weather, I'm going to be here. I'm going to be online. And that's is also something that the pandemic cost, and that's an opportunity for everyone. First of all, I would like to say hello to the people in the table, Ana Maria. I'm sorry, I'm confusing everyone. Ana Maria Ortiz and Ana Maria Vesga. Ana Maria Ortiz comes from the Santo Domingo Foundation. Ana Maria Vesga comes from Andy and Andrea Ramirez, who is a professor. I mean, a professor who was the leader of all this pandemic process, and I'm going to talk about it a little bit right now. And the people, Ms. Francisco, Dr. Zamora, Dr. Carrasquilla, thank you very much for being here. Thank you very much to our professors, Marta, Nubia, Rashid, David, Luis Jorge, who were also protagonists of this pandemic in the university, Dr. Elkin, and the people from the Ministry of Health. Thank you very much for all of your support during the pandemic, and we are waiting for that at some point our former Minister of Health, Fernando Ruiz, to arrive. So I'm going to start a little bit here, and then I would like to thank Andrea for the organization of this event. Thank you very much, Andrea, for this. Well, today we're having an event that also puts an end and a beginning. The end of this COVID-19 pandemic, and I've also seen another protagonist here of Covida in this university, Adriana Diaz. Welcome, welcome. Thank you very much for being here. And the beginning of what is going to be the post pandemic. And I really think that it is very important that as of today, we need to reflect about it. And at the end of the event, Andrea and myself are going to go back to this lessons learned that the pandemic left us because I really think that this is a right time. This is a right to get together, to gather what we learn, and to apply what we learn, not to live it just in papers and in articles and written down in literature and in lectures. What would I rescue from the pandemic and the lessons learned? First, that we need to leave that public and private discourse of two things that do not speak to each other and do not understand between each other. Us in universities, we live under that shadow, right, between public and private universities, that the investment should go to one sector and not another sector. And I will call everyone to stop separating everything just on water and oil that cannot be together. And during the pandemic, we actually demonstrated quite the opposite. So this is the public and the private part, the academia and the sector that sometimes is a little bit funny that I said the real sector and academic, as if we in the academic we're living in a little cloud outside the topics that actually happen in reality. Number two, the horrible dependence that we have in our country in many topics, particularly in technology and for basic products and inputs. With the professors over here, we put the diagnosis test laboratory, and my biggest angst was month after month to be if we were going to be able to get all the resources that we promised. So that dependency of so many things, of so many resources, and not only the dependency of purchases and everything else, but also the regulations that go against everything that for this to happen in a rightful way. And the third lesson learned was that during the pandemic, we paid the price of what we have destroyed, ignored, and this the national system of science and technology and innovation. And here in our country, we don't have a science, technology, and innovation system. We were producers of vaccines, Luis Jorge, Elkin, they know it, and we destroyed that capacity. And now we need to call Sinovac. We need to call, and in Medellin they are producing Baxtera, which is a national thing, which for me is something very, very right. I mean, that's a right thing to do. But we need to rebuild that capacity that we lost for not financing our national system of science, technology, and innovation. The budget of the ministry is laughable. We have half of the budget of the Ministry of Sports to build the knowledge society that the government says. I don't know how we're going to do it with the budget that we have of our 400 billion Colombian pesos of technology and science. And before that, we need to call as a community for that not to happen again. We need to call INVIMA and all the regulatory centers that somehow could facilitate that the next pandemic would be easier and we shouldn't live the same fears and calamities that we live throughout this pandemic. And I would like to pay homage to the project Covida of the Los Andes University, a person that is not with us today, Eduardo Perez, who was part of that Covida project. And all of the professors that participated in that effort. More than 150,000 free tests that we conducted to the population that were not having access to it. More than 110,000 vaccinations that we applied in localities in Bogota. We were the first to apply to migrant, undocumented migrant population. That is something very important. The hand of the Santo Domingo Foundation was key for that project of vaccination. I guess we changed the lives of many, many people and we saved lives. And we can say it like that. So, this is an event, and with that, I'm going to stop here. This is an event that closes and opens. And the pandemic demonstrated that we were able to do things, and it demonstrated that during a certain period of time, we were able to do those things that we were dreaming a lot of building between academic and private sector, between public and private. But let me remind you that the COVID-19 pandemic was over, but we're living another pandemic that could be very long lasting, which is climate change. Climate change that is also going to bring more zoonosis. So we are in a situation, a very difficult situation. And I guess that we can take advantage of what we learned for some months to putting in the long run in a pandemic that we're living right now. Thank you very much. Good morning, Silvia. Thank you very much for the invitation. For always, it is always very, it is always good to go back to our home for many years now. My name is Ana Maria Vesga. I am the Vice President of Health of Andy, and I would like to start by saying that us, as private sector, we have a very ample sector of health represented in Andy with 5 different chambers who are bringing together insurers, service providers, and technology providers for industrial gas, medical devices, and medical gas producers. And this is space, such as Silvia is telling us, this is the beginning and this is the end of what was experience of the country response against the pandemic. And we're going to have some space to just put more detail further ahead. Without a doubt, it leads a lot of reflections on one of those, and that's why it is important to go back to the academia today with these lessons learned. Is that you would expect that everything that we lived in this country and in the world in general is not shouldn't stay there in the story or the memory of what COVID was, because without a doubt, this is the first great pandemic that this generation lives or has lived. The response of this country, in particular, Organizia right now, was very positive. But we need to be prepared, most likely for other sanitary emergency situations and where all of these things shouldn't stay only written down in a paper and in the memory. So going back in this lessons learned is very positive, and I really think that one, or maybe perhaps for us in the private sector, one of the key elements for response of what we have in the situation of the previous years was a possibility of articulation between the public and private sector. I being able to break, as Silvia was saying, to break that barrier between private and public. As a matter of fact, what we saw here as a country was a very well coordinated response with great collaboration. You couldn't imagine what's the extent for it. Many of those things are silenced, many of those efforts are not well known, but what we know is that this was possible for a gigantic institutional effort of response. And now that Minister Reese is going to tell us here, he's going to tell us a little bit more how the capacity of a ministry was overflowed for giving the right response, but at the same time, the response of the private sector that comes from different parts made it possible for the country to step up. And not only the country, the world to have access to innovation, for us to have access to vaccinations in a record time, that the tests could be rolled out very quickly, that the responses with errors and without errors, it is very easy to judge afterwards. And then maybe we have a thousand things that we would have done better, but without an instructions manual and without previous guidance, the world came into a situation that wasn't ready. And here we had a great response. Of course, the number of deaths is never going to be minor when we compare. I don't like it when we compare numbers of deaths. I mean, one single death is painful. But beyond that is the institutional capacity of a country to have an articulate response towards it. So thank you very much for opening a response at this space. When we talked to Chatham House just a while ago, and Andrea, of how to document everything that was done around the pandemic, we found the opportunity for this not to be forgotten, for this to stay in a shelf and in the memory of what the response for COVID was. But we need to think what are the opportunities that we have as a country in terms of institutional strengthening and in terms of recovery of capacities of science and technology. We're going to talk further ahead what the great reflection around the sanitary autonomy is. I think that is the closure of the borders and the closure of the health resources. And we have Leonardo Lagos here for during a lot of afternoons where we're seeing that we have a lot of things that, for the lack of supply in medications, for instance, we didn't have painkillers, we didn't have, what's the one that put you down to sleep? Oh, yeah, sedatives. We didn't have sedatives for intubation. We actually lived a very critical situation, and what lessons we learned, what the need that the country needs to recover its own strategic response capacity in terms of technology. So all of that is a lessons learned. It's something that we should learn. We celebrate this space and thank you very much, Ana Maria Ortiz, for the Santo Domingo Foundation. Andrea, your work has been amazing. And it is so great for you guys that are joining us today and for everyone that is online. Thank you. Good morning. Let me introduce myself. My name is Ana Maria Ortiz. I am the health manager of Santo Domingo Foundation. First of all, I would like to thank Silvia for receiving us here in this beautiful space. Andrea, thank you very much for the organization of this event. We've had very, very interesting alliances, and Ana Maria Vesga, who is one of our leaders in our foundation in terms of health. Thank you so much. I guess that one of the lessons learned for us as foundation inside the organization with the COVID things is that together we're more, and that has some implications. Together means we need to bring up academia, private sector, public sector, but also bringing the communities together and bringing them in the same boat. That generated very important institutional changes and helped us focus the type of social investment that the foundation does. Putting a very high bar, yes, but a very interesting impact of what we do, not only in health care, but also in education, environment, and territory development. It has been very important for us to have projects such as COVID with other Organizations jumped in, Dunkin' Donuts in Colombia, creating that community adherence that we needed in such an important moment to have the help of the University of Los Andes team generating the territory spaces. It goes against the current, against the very important security processes, rainfall, water, everything that we lived throughout that time. That was one of the most important activities, and how each and every one of us has a fundamental role in what we do. Particularly today, we need to move on. We need to continue and move forward and to keep on building in an articulated way. We realize that decision making based on evidence actually creates an impact, a sustainable impact in a country such as ours. Know how to gather data, how to obtain information, the lessons learned that for us were fundamental, and that hopefully they will guide the work in a couple of years. We hopefully have such available allies such as yours, and we can actually increase our allies pool by understanding this. Together we're more. We also would like to thank the Santa Fe de Bogota Foundation, who were a very strong ally for us, understanding that in addition of having technical expertise, we also need to create more impact on it. So thank you very much, and hopefully this event is good for you. We had a great effort putting this together. Thank you so much. Good morning, everyone. My name is Sandra Ramirez. I'm an assistant professor of the medicine school. I have the privilege to coordinate with my colleagues that just introduced the event, this colloquium, and this space so we can have a conversation. This has been a very, very hard work after 3 years trying to give a reflection and trying to summarize how that response of our country was in our region. So I hope you enjoy this event. I'm going to give you my presentation, and then after that, we're going to start with our case study with our experts coming from many parts. Thank you very much for your guests. We're already here. Everyone is already here. We can start. All right, so very briefly, I'm going to give you the introduction to this event. Can you see it? Esteban? Thank you so much. Better? Okay, perfect. All right. So, as Professor Silvia was talking, or she was saying, maybe today we're closing a cycle that for the university was very important, and with all the universities, Alice, and this is the COVID COVID, the project COVID, which was the multi-sector response against the challenge that the pandemic represented for us in our country for COVID-19. Of course, we need to mention our allies such as the Ministry of Health, the National University, the Santo Domingo Foundation, the Santa Fe de Bogota Foundation, the National Association of Entrepreneurs, the National Academy of Medicine, and more than 100 allies that got together so we can fight together and have the best response against this challenge. As you can see here, during 2020 and 2021, we had COVID, La Prueba es de Todos, the test is for everyone, where we applied more than 100,000 tests throughout the city. Then between 2021 and and early 2022 was La COVID, la vacuna es de todos, vaccination is for everyone. And a little bit this year we were working about the evaluation of that preparation and response and the lessons learned for this pandemic. For many months now, we haven't talked about the pandemic, but it is very important to learn what was good, what can be improved, and how we can be better prepared for an event of such a magnitude. All the epidemiologists and all the health professionals know that it is very probable in the next years, maybe in our lives, maybe we can see another event such as this one. So, related to this situation of the evaluation of the preparation and the lessons learned for COVID 19 in Colombia and Latin America, we've proposed to do a very robust exercise from the scientific point of view so we can deliver a document that might work as an agenda for the decision makers and our own agenda for everyone so we can be prepared for the future. So, we've been reviewing the literature. We've created interview and roundtables with more than 50 experts and key informants in all the levels of action, such as the national and subnational government, academia, and multiple multilateral organizations. So maybe this is the only event that has, the only study that has included a lot of experts of the region. These interviews were conducted starting March this year, and as of and as of today, we're already analyzing them and concluding them. So today is like the closure of these 3 years of work, and it's going to have a very punctual product that we're going to be sharing with all of you. The main purposes of this colloquium are that through the study cases that we're going to see further ahead and through the panels, we can discuss the response and the lessons learned for the COVID 19 pandemic in Colombia and some of the countries in the Americas. That we could present through the report that we're going to produce some recommendations and a national agenda proposal for the management of post-pandemic, and we could inform the role of Colombia and the potential contributions for the health development of the region. Our country probably was one of with the best response of all the for all the regions in the Americas. So we need to raise our voice and we need to make those strengths evident in this new government. Very briefly, I'm going to show you some preliminary response, like in a conversation starters for the discussion. The first thing, without reading the numbers, if you're reading here, what we know is that Latin America and the Caribbean has at least 13% of the confirmed cases, but almost 30% of mortality. And this is disproportionate representations considering that our region has less than 9% of the worldwide population. We need to find out what is happening or what happened. However, we are the people with the highest, we're one of the regions with the highest percentage of vaccination, and we have a couple of opportunities here to increase. Very briefly here, some countries have were more affected than others, particularly Brazil, Argentina, Mexico, and Colombia were among the first, the countries with the highest rank of incidence. You can see here in the last column the share compared to the other countries of Latin America. And also here we can see the confirmed mortality here. In general, of course, Brazil was one of the most affected, but we can also see that Peru was also one of the most affected one, and the ones that we can learn more lessons to it. We can see here, as I mentioned, for the country, we have the highest rates of vaccination around the world, and on this we can be building to have to have a better response against emergencies in the future. Some of the health results can be explained by a context situation. The first thing is that we have a region that is densely populated with more than 650 million inhabitants in a territory that is not as extensive as any other territory. We have a lot of inequality in health. This is the Gini average, but we know that many countries, such as Brazil, Colombia, and Peru, with higher Ginis, with more inequality, a very high percentage of informal work, a very high level of poverty, and that is, of course, made it difficult for the implementation for some measurements for mitigating the transmission of the virus. And also, we have a very high corruption perception, and this is an index when we ask the civil society and the people what is their corruption percentage of the leaders and the government. This is a region that is permeated with this, and of course, the low confidence of the population with the leaders. We're going to see how this affects the adherence of public health. It is also a region where the burden of non-communicable diseases is very important. At least 5.5 million people died during 2019 for this burden of disease. So it is very important, and this is today's objective of this project that we came up with all of our allies to understand a little bit which are the determining for the preparation and response of the pandemic of these countries in the region. Determinations for prevention have to do with more intermediate and longer intermediate determinants such as institutional, social, economic, political, and environmental, and of course the determinants of that global environment where everyone was involved. And at that point, we didn't understand the importance of such determinants such as availability and access of global public wealth, international regulations, health governance, regulation frameworks, and disinformation and fake news. That is the purpose that we are doing for today, and that we came together with the university and our allies during the last year. This is, of course, is going to have great things as incidence and vaccination rates. So, some of the preliminary results of our project that I'm going to introduce to you around these four blocks, which is number one, prevention, preparation, or response against the pandemic and outcomes in health, facilitators and barriers for the implementation of a national plan for the prevention, preparation, and response against the pandemic, lessons learned for the implementation of these plans, and what will be the future and the agenda that we need to follow for future events or similar events for the country and the region. All of these results include the interviews that we've done with key actors in Colombia, Brazil, Peru, and Argentina. First, I'm going to introduce this very, very quickly, that you can see what these experts are referring to with the relation with the elements that have to do with the report of incidents or with the incidents per se in our countries. You're going to see here in this color the common elements, and of course, you see notification and the real vigilance systems were very important for everyone that we interviewed. Initially, the accessibility of the data and the transparency, another key element, and the existence of a national system of laboratory and the capacity and quality for the detection of diseases, priority diseases, that was fundamental when we're trying to understand why the incidence was manifested in that way. Now, in terms of mortality, the experts said that the installed capacity, the supply chain, and the clinical and medical attention in hospitals was something very relevant. Dr. Victor Zamora is going to talk about it a little bit later. The multi-sector response and the risk communication to the population, the accessibility of epidemiological vigilance and its transparency information, and in terms of vaccination, of course, the multi-sector response and the risk communication. You have regular programs of inoculation as a tradition in our region, and of course, the accessibility for the epidemiology vigilance information. Now, for the factors that have implemented a plan of prevention and response in these countries, the experts agreed They were saying that the trust in science was a determination for facilitating the implementation of that plan. In addition, some other indications, such as literacy, life expectancy in their countries, and the possibility of the people to understand those guidelines that were implemented and the recommendations that were being made, the universal health care system, the health security system, and the public health funding was also key for the implementation of any activity, in addition for the capacity and infrastructure of the healthcare system. Now, in terms of the barriers for the implementation of plans, the experts foresee that the incommunicable chronic diseases capacity and the health status of the population was one of the greatest barriers for having success in this. Corruption and that for the context, you can see that this was very important for all the countries. Of course, the role for infodemia and disinformation for COVID-19, and also the confidence of the political leaders were one of the main barriers, in addition to poverty. Dr. David Bardet is going to talk about it later. This is also very important to see that the activity and the relationship with those communities was very important. However, the difficulty of creating that link with the community was one of the barriers to implement the plan. In terms of lessons learned, we can see that the main lessons learned are around the political, social, and economic context of the country and the capacity of the healthcare system to respond, the pandemic governance, and the selections or the choices around that governance were very, very frequent. Other lessons around the implementation of the plans and sanitary sovereignty, lessons around politics and politicization of the pandemic and the national healthcare system, and around the multi sector action and the pandemic funding. Meaning, you can see here that some other context factors or factors related with the political, social, and economic context of the country are fundamental, and we need to consider them for our future. Just to show you here very quickly, among the actors that these experts mention as keys to create any response for the preparation and response, we have the academia, scientific societies, medical societies, and institutes. We can also have very important actors of this public ministry, such as the Ministry of Health, the National Healthcare Systems, INVIMA, the sanitary vigilance agencies, and scientific and technical councils within the public sector. Some other actors within the regional governments and the Congress, for instance, and associations for such as ANDI and base organization, grassroots organizations, and OPS, well, HPO, PHO, they were very important for this. Now, to finish, I would like to leave here. I would like to leave this reflection. This is gonna be very helpful for this for our conversations. Is that when we ask these experts about the perception for the support for the implementation of this activity for the preparation and response against pandemic in the next 12 months, in part of from the decision makers. Number one, and I was expecting that the majority was telling us that they were very much to put this in our agenda. However, what we saw is that this is to think about the origins of the expert. The academics were a little bit more skeptical. The multilateral presence, they were the ones that were mentioning were a little bit more of will, and the people from government, the majority, tell us that the leaders were not very much in charge of put those topics in their agenda. When we see this by country, we can see this in general. Argentina and Colombia were the ones with a better and the more positive perception, but the majority of experts were telling us that we just have a little bit of will to handle this. You're going to see that, we see in the context and what we see in Brazil and Peru, the majority of the people were mentioning that the leaders were not very much in agreement. So, in general, we're observing little interest to doing the preparation and the response against the pandemic to do a priority in the public healthcare agenda of the countries, and there is a very important threat on public health based on evidence due to sanitary issues that compete against each other, and also for the electoral agenda that were happening at the same time during this pandemic. So that's pretty much the conversation opening for our colloquium. I would like to give you the warmest welcome again, and I have the pleasure to introduce our experts, guests that are going to be leading the cases of study. Our first expert is Dr. Fernando Ruiz. We have the honor of having him here with us. Thank you. Okay, I have the honor to introduce Dr. Fernando Ruiz. We have his amazing participation today. We're very, very thankful. Dr. Fernando Ruiz, he's a physician with Masters of Occupational Health with a PhD in public health. He is an expert of public health and services and health services. The areas that he has been consultant of the World Bank and the Inter-American Development Bank. He had a position of the Ministry of Health between 20 and 2022, Vice Minister of Public Health and Service Provider, in charge of the SEDIC Cancer Research Center, and for 20 years he has been the director for the project center for the SEDEX, for the Center for the Javeriana University. Welcome, Doctor. Well, thank you very much. Thank you very much, Dr. Andrea. Good morning, everyone. I would like to start by saying that they asked me to focus my presentation in terms of for the topic of governance for the pandemic in Colombia, particularly for the role of the sanitary sovereignty. I would like to tell you that, of course, this presentation is a bias because I was in charge of the attention of the pandemic. So obviously, we need to consider that all the time. So, with that explanation of that situation, I'm going to be more, I'm going to have more peace of mind just to present you what we had it with my own perception. I would like to start by saying that I don't know how to switch to change the slide. It is not working. There you go. Well, first, the topic of governance. I was analyzing this topic a little bit and I wanted to take a little reference framework, a little bit older, but I guess that it works and it's going to be help us out to analyze a little bit more and to put this into context. And it has to do with the World Bank in this definition of governance, the way that the power is used for the management of economic resources and social resources for the development, and it explains four main components. First, the governance to the respect of the state of law, then equal and public management, there's responsibility and accountability for transparency of accessible and available information. And number five, I think that that's mine. I think that we need to have more for the directory of and the self-sufficiency and sovereignty. I guess that is very important. Now, by doing an analysis of the context in terms of the law, the state of law, I think that these topics are very fundamental. I think that this is very important for the attention of the pandemic. The first important topic in the rule of law is the public health prevalence. In a pandemic, it is necessary that public health becomes the central axis of the functionality of the state, of the law. So many of us, we haven't ever been in a pandemic, and we haven't understood what that means for the rule of law to have a pandemic. For more than 2 years, our country, Colombia, in all its institutional operation, for legal and judicial and for norms, was depending on one single resolution of the Ministry of Health. Actually, all the framework of emergency decrees that was a declaration of a sanitary emergency. That is not what a pandemic signifies or means. As something fortunate that we have in Colombia, a country that everything is based in legality, and the legality is such an important part of us, is that the development plan for the President Santos when I became a minister, and after what we have with what happened with Zika and chikungunya, we needed we decided to publish a paper for the development plan to allow the formulation with the different specifications that we end up for the sanitary emergency. Thanks to that, we were able to do it, and for the public health and attention of the pandemic. Second, something very important, we have the limits for the emergency statutes. We of course didn't have that much of experience. We were demonstrated that in every day I feel that things were done correctly, and all the emergency decrees of all the different parts that were issued by the national governments. There were very few that were not able to be feasible. And actually, the structure that we talked about for a topic that needs to be as a lesson learned, a very important lesson learned. The third topic, of course, is that is very important, the prevalence of the general interest. The Colombian system is a profoundly individual system where the individual rights for decades have been very relevant for the analysis based on different analysis and for the legal actions. From one moment to another, in a situation where the prevalence of the general interest is fundamental, of course, there is a conflict and a complex situation that, fortunately, I understand, and I appreciate that actually the court related very well. The tutorship that was presented against the Ministry of Health, practically only 3% were lost. Many of them were actually won in the second round. And third, a little bit more operational for the actions of public health that we needed to take for the development of the care and prevention. Caution and prevention. This is very important in terms of this rule of law, and this is something that we need to take again in the future. I would like to start for the most easy part in terms of what the public and equal and efficient management in the second axis of governance. What do we do? Lower mortality compared to South America, very similar to European or North America with a more limited resources and clearly with an expensive public health that is maybe 2, 3, sometimes 6 times lower than developed countries. Ranking the 98th position for the post-vaccination mortality in the last year, meaning the final effect of our vaccination plan against the risks or the post-vaccination risks, they have us in the mortality position number 98. Somehow, some of the decisions that we took, particularly for the approximation of the different vaccinations with 5 different vaccines that Colombia took and the process of vaccination based on risks, somehow had a very relevant result. Second topic, the strengthening of the healthcare system. Colombia built an adequate and put together 23 units of intensive care in the poorest parts and the farthest away part of the country, and places without intensive cares in Amazonia and in cities like Buenaventura, when incredibly they didn't have an intensive care unit, they were able to build. We put together more than 500 units of unit care from 5,300 to 13,000 beds. We saw 160,000 patients in ICU during the pandemic. We purchased 84 million and applied 87 millions of vaccines. We applied more than we purchased because we're not counting the donations that we received. And something that is very, very important is the zero out-of-pocket expense for the COVID services. In Colombia, and the difference compared to other countries in the world, the Colombian situation had intensive care, medical attention, and vaccination without paying. The recovery of the rights, economic rights, the opening of the different sectors, of the economic sectors, including education and culture. And I guess the thing that here we need to say that in Colombia, it was a lie that we open bars before schools. If you see the legal framework indicates that at least 8 or 10 months before we were presenting the guidelines for opening schools before opening bars and restaurants. The economic activation for the results, I would think that it is very important because that was the third purpose of our country. The other purposes were to protect the health, to protect the system, and to recover the rights. With a growth of 10.7% in 2021 and an expectation of 7.1% in 2022. A lot of that growth is due to the fact that the opening that Colombia had for its social and economic structure was way faster compared to other countries around the world. And that led us to be in the global position and for the Bloomberg's Resilience Index, and we're the first countries with a better development country with Turkey. Second topic that has been very important for the development of the pandemic, the transparency with available information and accessible information, fundamental risk communication. Everyone became bored for the presidency programs, but we had 270 sessions, particularly that everyone, like us, that we needed to go there and to talk to everyone. But I guess that is a fundamental example of how a government responds and responds on a daily basis by informing what's happening every day at 6 p.m. during 270 days. The permanent presence of the Ministry of Health in the country. In our Ministry of Health, we have a lot of members here in the Ministry of Health, and was a ministry that was fully open, and was completely open and focused on the regions. From Wednesday night to Sunday morning, the Ministry of Health was everywhere around, seeing the necessity of the regions. It is a country of territories, it is a country of regions, and it was exerted for the regions. The permanent presence of the regional and national media, every crisis and every situation that occurred during the pandemic, not only the ministry, but also the different deans and vice ministers, they were all focused to answer each of the questions that the journalists had. I mean, we were not hiding, we were not trying to dodge the questions. That was a ministry that was directed to answer the problems of the city. The intersector coordination. We had the opportunity to have the picture to having more than 120 unified situations. I mean, every Friday from 9 to 12 in noon, we were sitting but receiving instruction and to talk about the problems that each of the different pandemic process had, and that institutionality was able to be built, and it was absolutely important to have a single communication within the system. And all of the territory program models for the crisis situations, as well as the development of digital health, to be able to hand out daily information to all the Colombian population. Now, third topic in terms of governance, the responsibility and imputability. I guess that Colombia also achieved a very interesting development in what this means, particularly by considering this chapter that is absolutely relevant for building public trust. We started with a healthcare system with a very low legitimation, with a lot, with in crisis for many years, with a lot of actors and sectors, with a low perception of public expression, and the highest challenge that we had during the pandemic is to build the confidence in the ministry, confidence for the response. And if we go over what happened during the last 3 years, most of the crises where we were doubting the possibility or the capacities of the public healthcare system. We had a very focused effort, and that focused effort was under those elements and general rules. Number one, the equality among Colombians as a basic rule. Equality as a basic rule. Here in Colombia, we didn't see what we saw in other countries of privileges in terms of vaccination, privileges in the access of intensive care, privileges in terms of hospitalization. Here, everyone was vaccinated the moment that we were supposed to be vaccinated. And that is for absolutely clear and intentional decision from the sanitary authority. Also, we created a fundamental decision that I thought there was for the integration of the greatest cities for the unit of intensive cares with the centralization around the urgent care regulation centers, where the patients arriving into the ICU had the same opportunity be to be part to to be well, whether private or public, and the maintenance of respect and the warranty against health, the mechanisms for the law reivindications, the tutorships, all the tutorships that we were facing with were thousands. They were clarified. We took position, and as a ministry, I needed to have the position in some of them, and at some case not accepting the tutorship, but always talking about with the different judges around the country because we think that that part was absolutely important as well as the warranty of right. And also in the design of special mechanisms for the resolution of eventual damages for the strategy, particularly for the vaccination plan. Per the initiative of the ministry, even though this was an advance for the vaccination ministry that we supported, we included within the law special mechanisms for solving some cases where we considered that we were able to have a claiming of the citizens against certain damages caused by vaccination and other effects. That mechanism, it is there. Fortunately, that hasn't been used that much, but of course, we have some cases that are subject to review. And the fact that those existed are fundamental as a general rule for the responsibilities and accountability. Particular rules, prioritization depending on risk. We as Colombians, we understood and we accepted that the ministry was absolutely transparent and the prioritization should be always depending on risk, age, comorbidities, particular situations that would let us to defend certain type of people based on the risk they had, and protection of special groups such as healthcare personnel, incarcerated population, healthcare personnel who were protected since the beginning. The declaration of this disease as a professional disease, that is something that's a first that has never happened before to protect the healthcare provider and the healthcare workers. And in terms of accountability, the increase of control processes with simultaneous auditories with controllership and the different entities that so far the ministry and the National Ministry of Health and other sectors of the health have been working on. Of course, lastly, all the accountability process. Of course, that fundamental framework, which was absolutely intentional and consolidated, and that has been represented in each of the decisions and norms taken by the Ministry of Health, has been a fundamental element for the citizens to be confident and to believe in the public institution for the attention of the pandemic. Lastly, and something that has to do with safety and sovereignty and independence, I think that there are some topics that we need to analyze for the future. For for some in-depth analysis, that particularly I think that that we need to the healthcare, the health authority against the status quo of the law against the government and against the other social and economic sectors. I would like to say that we were fortunate enough that with the government, with a situation that was evidently not very easy at first, that I wanted to give you an example for it with my own example, that there's a minister coming to the coalition of government, and then after the 3 days, they needed to face the worst threat, the public threat that the country has had and the world has ever had. Something very important for the government, being the president of the country and the ministry, and the situation was not. That is very clear of transparency that the confidence and the Ministry of Health that the President of the Republic was absolute, and that is an essential part of this process. Now, with other powers, particularly with the different courts, we had a great job in documentation, an explanation of the different difficulties, and the courts of the country were absolutely important for this process, as many other social sectors and economic sectors, such as the entrepreneurs, businessmen, industry, cultural sector, with a great capacity of comprehension of what a pandemic means. That is absolutely relevant. Another important topic for the technical dilemma for the incentives. We were arrived into a pandemic. All the governments that were recently elected, the majority were coming with the program of government, and in that government program, I mean, we didn't consider the pandemic for this, and it changed our process. And then the pandemic becomes, of course, a subject of the main subject of the political action of the majority of the governors and the people in government. So we have a very, very large friction between government, national government, and more than national government, the health authority and local governments. And that is very clearly, you knew it very clearly. And then we have that work of negotiation and management and frictions and for finding solutions. And the fundamental event of this was the consolidation of the committees. Number one, for our technical decision, that all the decisions needed to be taken after scientific basis, and that we have committees for vaccination, for epidemiology, for advisory, in which we had some agents and people that not necessarily were for the government, and that we might have a conversation and to take decisions, and those committees In this framework, a lot of the decisions were taken, and for the territory governments, either national or territory, that was very important to consolidate that sanitary or health authority. And that has to do with the integrity of the strategy of the national plan against the response that we presented at first with the four stages compared to each of the that for the government issues or government officials. There were people that wanted to close roads, for example, of the departments, a lot of things. And after that initial process, I guess that we had a lot of progress compared to that. The challenge of obtaining the confidence and the trust of the community and the funding, which is an absolutely relevant aspect of creating the FOME, of creating the central fundings to make those funds available and reviewed and analyzed for easy decision making, for having a better meeting with the external members. That was probably a great decision to address the pandemic with a clarity that these resources would finance again, with FOME. Health security, the expense with public interest against the cost and benefit. We're coming with a healthcare system where optimization was the most important part, but of course, with a very important part always focused in health. But suddenly, this is part of the pandemic where this is more relevant and this is part of the decision. However, with the Ministry of the Internal Revenue Service, we always conducted studies to evaluate the cost and benefits of actions such as the vaccination plan. And there were models that were published when a lot of universities participated. Decision making based on evidence. And I'm going to gather all the possibilities of the committees here about the construction of evidence based on all the academic environment. The mathematical models were always consolidated and built with the academia, with different entities. And the institute became at some point a hub where we were putting together a lot of that information and all of that data. And another very important topic is the vigilance for the health authority and obviously the control organizations. Now, for the sanitary sovereignty, it is a very critical topic not only for Colombia but for the world. It's the situation of nationalisms of multilateral aspects. Colombia was able to obtain its 20 millions of vaccinations that was purchased through COVAX mechanism, but definitely we suffered a lot to acquire vaccinations, to purchase ventilators, and to purchase equipment. And we suffered because, of course, there were decisions to protect countries with, the producers, the country's producers of those technologies. And that, of course, created a very important effect. We were able to do it well. We were able to see that for our country, by purchasing the medical elements and medical equipment such as ventilators, countries that purchase more with better prices. All of the reviews that all the controllership was telling us demonstrated that Colombia finally was able to purchase that from a ministry that was not very much in an ability to do it. And lastly, the topic for the limits of intellectual property versus traumatism. That is an element to analyze for the purchase of vaccinations. A lot of experts, many experts, including academic experts, were telling us that Colombia was about to start the vaccination plan in 2023, 2026, 2027, and some other sectors were saying that why we were purchasing vaccination if with bilateral contracts that the important part was to affect intellectual property rights for those developing the vaccination. We took a very pragmatic decision, and that needs to be clear. We had a pragmatic decision that the topic for intellectual property is very important. The earnings of Colombia in that topic are fundamental. I guess I have the moral authority, and I'm telling you this. I have been the only vice minister in the history of Colombia who took a personal and patrimonial risk of signing a public interest situation for a drug in Colombia when I was a vice minister. But very clearly, we cannot put aside the destiny of a country in a pandemic in hands of a discussion, an unbalanced discussion that wouldn't give us a result in the short term, such as the intellectual property aspect. We need to have a pragmatic situation. We need to purchase vaccines, and we need to fight for purchasing that. That is a very important part of what we did. And lastly, just to finalize this, I would like to leave you with an anecdote. Colombia had health sovereignty and safety up to the 70s, let's say. For in the 80s, Colombia declared the eradication of the for the smallpox in Colombia with the vaccination, something that started in 1929 with the Samper Institution and the Vaccination Institute, and Colombia was able to do it. And that consolidation, that possibility was consolidated by the National Institute of Health throughout its history, but unfortunately we lost that capacity and that's sovereignty in 2001 when Colombia produced its last vaccine. We, us, and with the context that, that Dr. Adriana was saying with her presentation, we cannot leave this pandemic to just pass and not learn nothing. We need to persist, and the institution of the health in Colombia needs to be very consistent. We need to build sovereignty and safety in Colombia that includes the possibility of producing vaccinations and producing medicines and elements that are essential for our country. Now, and everything that has to do and the consequence for such in history, such as Dr. Samper, Dr. Martinez, Dr. Guerras, that comes a little bit more closer. And most of the directors of the institutes that have been fighting, have been working for having elements to make sure that we were able to have our own sanitary independence. I guess that Marta Espina was telling us of a crisis that took us from 2004 up to 2018 to finish that crisis in a permanent sanitary emergency for anti-venom availability in Colombia. And only with a persistent effort with the ministry and the institute, with an investment with Colombia, we'd have a sanitary in a sanitary emergency with a country without anti-venom, where we have more than 5,000 incidents of situations where we need anti-venom. And the ministers that are coming in the future, they need to be consequent with that responsibility of consolidating and to build the independence, the healthcare independence in our country. Thank you very much. Thank you very much, Dr. Fernando Ruiz. It was a pleasure and an honor to have you here with us. Now, I'm going to yield the floor to Dr. Victor Zamora for our next presentation. Dr. Victor Zamora is here today from Peru. He is a doctor of the National Mayor University in San Marcos. He's a master in management, planification, and policies of healthcare in the Nuffield Center for International Health and the Development of the Leeds University in England. He had a postgraduate studies of economy and health in Pompeu Fabra University in Barcelona. He has been an international official for the Pan American Organization of Health, World Health Organization, and the Ministry of Health in Peru in 2020. He is currently the academic coordinator of the specialization program in government and public policies of the Government School of the Pontificia University of Peru. Welcome, Dr. Zamora. Good morning, everyone. Can you hear me? Yes. Thank you very much for the honor that you have given me participating in this event. I would like to congratulate the organization and the university that are joining to the organization of this, and of course, Colombia, that does this reflection exercise of extracting the lessons of such an impactful event. And and also Colombia as a sanitary authority and medicals, and as a sanitary dedicated to public health. We've always seen Colombia as an example. This presentation comes from another point from the spectrum of the pandemic, the performance of the health systems in Latin America. And talking about this, I would like to leave this. What happens or what's remained in the narrative around the world and the Peruvian system around the pandemic? First, the very high mortality rate. We are top rank globally for the mortality rate. The second thing that we have in Peru was that the swift, how swiftly and how easy it was for the social restriction measures. We were one of the first countries of using it and using it in an absolute way, pretty much in every aspect. Third, and that is maybe you remember that about the crisis in the Peruvian case for the oxygen crisis. And alongside Bolivia, Brazil, Argentina, Mexico, we faced during the pandemic. Fourth is probably as vacuna, vaccination gate, where a group of people with access of power use that power to be the first one to receive a vaccination before the declaration of the vaccination starts. And the registry is taken to Peru with other countries in Latin America with exceptional levels of vaccination, very high. In Peru, at this point, we have almost 80% of their population vaccination with their third doses. So it is a country that, as a matter of fact, can be classified according to the resilience incidents against events of this as a low performance country with a low resilient healthcare system. One of those elements of the low resilience is the first level of attention. But in order to go to the first level of attention, I would like to give you a context of the performance of the Peruvian system. As I've been saying, this is the graph that you know. Peru is very, very much above the rest of the countries with very high levels of mortality rates. But we need to consider something. Since this is an informal auditorium, the comparison is made against different measurements. Peru took the decision of including all mortality excess as a COVID diagnosis, which didn't happen with Mexico, with Brazil, and with other countries. Therefore, the numerator is extraordinarily big. That doesn't mean that those 230,000 deceased during the pandemic do not exist. Of course, they exist. However, for purposes of comparison, we still have some pending things to do to standardize our comparisons. But after that, let's start with these 230,000 deaths, which give us a great mortality rate, and we need to We need to face that. First, the first thing that I'm going to tell you about is the fractures of the Peruvian system when the pandemic arrives. The first fracture is a structural, what we see in Latin America. The one that put Latin America as the region with the highest levels of mortality in the pandemic around the world. One out of three deceased by COVID around the world lived in Latin America. And of course, the inequality and poverty are part of the aspect that give us that. And this Peru and those conditions of living in Latin America, it is very difficult to stop contagion. The difference between becoming infected and not becoming infected is not given by the Ministry of Health, but is given by the conditions of life. So let me give you some reference over here. 30% of poverty, 70% of informal employment, 80% of manual employment. Manual employment impedes people to do a virtual employment. Very, very little penetration of internet, of the use of computers. Even half of that population living without a fridge, for example. Things that, of course, forces people to go out every day to get food. With 2 million of Peruvians living in Lima, a city of 10 million with access to clear water, to safe water. I'm going to compare Colombia, the comparison between Peru and Colombia. Colombia has 50 million people, Peru has 30 million people. We invest 2 percentage points less of the GDP compared to you. And in terms of public health, we invest 1 percentage point less compared to you. So, the pandemic arrives with with less population, but with the healthcare system with a lower level of investment, and also with life conditions that are or that favor the dissemination of the virus. Another second fracture is the weak governance in comparison with the extraordinary exposition of Mr. Vice Minister, the Vice Minister of Health in Colombia. In the Peruvian case, the governance is very weak, and it still is. We probably you know us of for the flick and the weak situation or the huge polarization, political polarization that we have in Peru. Right in the middle of the pandemic, since the beginning to now, we've been having three different Congresses, five different presidents, and we are counting the 16th Minister of Health. This picture is of November, a great social mobilization against the transitory government that lasted for 5 days. We are very, very highly polarized. This polarization is expressed not only in the lack of trust that a citizenship has compared to the government, the polarization against those in charge of the government, but also the polarization with the different citizens. The lack of confidence is very profound, so it is very difficult. It has been very difficult, and it's still very difficult to unify the country behind a single purpose compared to what was presented here. One third fracture, and just going into matter, is the scarcity of the Peruvian healthcare system. Unfortunately, this slide is not helping, but this is just to give you an overview of how far away we are in terms of total expense in health, as you can see in the far right chart. That red bar is Peru. We are one of the countries that invests the less amount in the Americas. We're pretty much the last one. That is expressed in the lower right side chart. In the first bar, the lowest bar, in terms of ICUs available bed, is Peru. That is before the pandemic. Now, to give you or to reflect this difference of capacities, when the pandemic arrives, probably, and according to the literature that I've been reviewing, the information has been very diverse. And the pandemic finds Colombia with approximately between 5 and 7,000 ICU beds operating for a population of 51 million people, right? Now, in the case of Peru, the pandemic finds for 100 ICU beds, 100 for a 30 million population. As of today in Peru, we have 2,500 beds, half to what we are supposed to having, at least 5,000 beds. Now, the scarcity was extreme, and it's still very, very profound. Now, when you here during the first wave were able to perform around 50,000 tests, in Peru, we were only rolling out 500. 500 molecular tests per day because we were only have one single operational lab in the city of Lima. All of the samples that were gathered, that were sent to Lima, making it not only inefficient in terms of response, inefficient in every aspect. I mean, we didn't have enough coverage, and the results were very late or never came. As of today, the capacity of Peru has been increased to 120 labs conducting this health. And we were able to do around 20,000 tests per day. Half or less than half of Colombia was doing at the beginning of the pandemic. Our capacity has been increased, but it's still not in charge. Well, as of today, we have more than 100 public and 60 private, being the public aspects, the private capacity being higher than the public capacity. And in third place, the upper right chart, the information is not as important as the chart by itself, is the availability of human resources measured as the team of health, you know, OGB, nurses, and physicians for 100,000 citizens. Peru is in the lower limit established by the World Health Organization. Here we have the resources that we need, and the most part is focused in Lima. But if we conduct a more specific analysis, the deficit of medical specialties is, of course, a sample of the fracture, of the structural fractures that we have in our healthcare system. For instance, in medical specialties in general, we have a deficit of around 25,000 specialists of different specialties. Now, in intensive care, we have one of the lowest rates of specialists for 100,000 people. In ICU, we only have 700 medical professional specialists in intensivists, in intensive care for that country, 700. So you might understand that the capacity of response in terms of beds, ventilators, etc., is very limited. And we added a measure of protection of the workers, healthcare workers, to determine that those with comorbidities or that were older than 60 years old, they needed to go back to their homes to do telemedicine because the risk for the individual safety was very high. Workers developed or carried out their activities, and I'm going to take this to the next slide for your left. For the sanitary infrastructure, before the pandemic, we conducted a study to give a different orientation of investment to see how our system was in terms of infrastructure and equipment. In average, 90% of the Peruvian healthcare points do not comply with the right levels of promptness in terms or compared to their own infrastructure and equipment. The left bar is the first level of attention. The second bars are hospitals. Third are on the center is for specialty institutes. And the two at your right are for laboratories for both national and regional labs. Now, 90% of the Peruvian slides have deficit of infrastructure and equipment before the pandemic. So, if you put together the political and social context plus a healthcare system with those characteristics, you might understand why this sanitary results in Peru to our fracture social level, the pandemic grew very, very fast. And I'm going to the first level of attention. The first level of attention in Peru, the only one with an extensive network of first level of attention is the Ministry of Health. They have 8,000 establishments. All of those 8,000 establishments, only half of them have a doctor. The other half have healthcare professional, and many of them are only technicians. 70% of those establishments of health do not have internet access. 30% of those healthcare establishments, they don't have water or sewage services. You know, the scarcity, I mean, this is, but being the only actor offering the first level of attention, the Ministry of Health, the level of resolution is very low due to the conditions that they have been performing those with professionals and with doctors. However, this first level of attention is the one that has been able to produce an extraordinary performance of vaccination. This first level has been able to produce 80% of the Peruvian population to be vaccinated with 3 doses. How this paradox happens, there is an explanation here. And this is the explanation that Latin America has for the world of why, after starting with this situation, Latin America can say the world or tell the world that is the region with the better vaccination scheme. Historic applications. We have more than 30 years of sustained investment of the vaccination programs. Sustained. And that is maybe one of the values that we need to keep, sustain, or even improve. The capacity of the first level of attention of delivering essential services such as vaccination. That is a strength of all the public healthcare systems in Latin America and in Peru in particular. This first level of attention has been affected of this resolution situation not only for that, but for two decisions that were taken during the pandemic. Number one, the general quarantine, being under the quarantine situation, the commuting of the healthcare workers to those establishments, and of course, the population being able to go to those centers was very limited. And on the other hand, when we took the decision of taking back the doctors or the healthcare workers back with comorbidities and with that were older of 60 years. For example, if we have 2 people working in this institution, if one of them was supposed to go back or the 2 of them were supposed to go back, that center was closed. So we're trying to put some arrangements to try to cover that situation or to remediate that situation, but with very little. But the Ministry of, but the Peruvian healthcare system works as a small blanket. Either you cover your head or you cover your feet, but you cannot cover both of them. And we need to follow with that situation that you need to take drastic decisions in terms of being overflowed with the pandemic and with the hospital establishments in absolute crisis. We needed to take the decision of mobilizing human resources there where the situation was very critical in hospitals. An additional fracture of the Ministry of Health that took us, that we needed, that blow, that at the end of the day gave us a hit that hit us is the fragmentation of the healthcare system. Well, you can say, okay, how many healthcare systems do we have in a country? We have the public sector, we have the private sector, and the social security system, right? In Peru, this could be simplified, such as that system, but that's not the case. In the Peruvian social system, we have the Ministry of Health in your right, in your left. The light blue is Social Security, which is managed by the Ministry of Work. Then we have three different military healthcare system for the military, for the Marines, and for the Air Force, in charge of the Ministry of Defense. Then we have the Ministry of Health of the police forces, in charge of the Ministry of the Interior. And I'm just giving emphasis with the ministry because it has implications for governance. We, as Ministry of States, we have the same level, and we need to ask permission for the other ministries to intervene in the other actors. And now that we talk about with the penitentiary system, which is a priority for Peru, we have another ministry, which is the Ministry of Justice, which governs the Ministry of Health in jails or and those conglomerate are 24 subsystem of public healthcare systems with their own heads. The Ministry of Health needs to deal with 24 different heads of the actions that we need to take in terms of health, including emergency situations. So the fragmentation, in spite of the measures to be national, that we are in an emergency status, that we were declared of an emergency situation, they need to go through the filter of the division of the healthcare system with a different executive branch. I didn't put the Congress of the Republic here, which also plays a fundamental role. They need to comply in terms of decision making. So another things that I'm not going to talk that much about is management, weak management, decentralization, and dysfunction, and the corrosive effect of corruption. The Peruvian healthcare system, per a report of the controllership, is declared as the second most corrupt sector after the transportation sector. And such a fragmented system with with so many different decision-making processes, it could be very easily affected by corruption in their different levels. A very similar exercise that you conducted, I've just conducted in a personal way, and I've been participating in a study that tomorrow is going to be released in the Nature, in magazine Nature, which involves the interview of nearly 100 experts globally, whose results you're going to see tomorrow. And as soon as they are published, I'm going to share with you so you can have access to it. And we have determined the situation that for today on, we need 4 large interventions. First, more rule of law, more state, more government intervention. We need more government intervention in the terms of not only in terms of larger state, but we need to give a more a larger and weaker state produces this. The citizens do not have access to water, residence, internet. I'm not talking about a state of being the provider, but a strong state that would warranty basic services for the population and life conditions that will protect them. It includes supranational status. 2 weeks ago, a paper was published in the Lancet magazine in terms of how much added value the subnational our intergovernment organizations, the banking and technical aspects, bring to the table. And in reality, this subnational structure has arrived late. And well, the COVAX facility arrived in Colombia after many that, and that has purchased in a unilateral part. The same thing happened in Peru and the rest of Latin America. We received very little and very late. In second place, in terms of Peru, more ethics. And in every level, the pandemic worked as a space for the political fight, political confrontation. The pandemic, of course, was used for the fake news as well, and also for the proliferation of this press, sensationalism press. This was a part that many private sectors used it for obtaining more earnings compared to a natural state. That it was actually denounced by the groups of the private sector as very non-ethical practices in their sector. Now, in terms of the ethical part of the healthcare system, it is very helpful for us to keep on mentioning the vaccine gate part where the president was involved, actually, two ministers of state, two deans of the university, the researchers, the private sector, labs, even the head of the church in Peru. So, what we can see here is that we have a lot of work to do in terms of improving the ethics of the public administration, either by the official or the people working around the official. More science, and the Vice Dean has talked about it, and the people before me, of the necessity of recovering part of the lost capacity. In Peru, we used to produce vaccination. The smallpox vaccination arrived in Peru in 1918 or 1818 or 1818 during the Viceroy part before the independence to Peru as a live vaccination. And then with the National Institute of Peru, it produced vaccination. We actually exported vaccination. We produced anti-venom serum for snake bites. All of that capacity was lost during the 80s, basically, where we have a proliferation of the theory that of the minimal state. The state should not produce what the others can produce, and we went a little bit hard on that because other things that cannot be produced with the private sector that compared to what the state can produce, such as the anti-venom serums. That's just the field, the science production. Another field is to filter the science. During the pandemic, we have a lot of evidence that we need filters to determine the evidence for the decision making. The role of university and the university centers is key. And finally, more equality, which is something that I'm not repeating today, but we have that for this sector where the presence of the first level is being substantial because the first level of attention is being expressed with the private sector of health. The primary health attention is not the first level of health, is yet it is to intervene of the well-being to reproduce socially a good and as we can see here, as the most part of Latin America, we have a debt to pay that we cannot prolong. Before finishing, I would like to give you something to give a reflection. I would like to congratulate this exercise. And I would like to also tell you that I'm jealous, but in a good way, that you're doing because the pandemic, it is being removed from the public agenda. It is not part of the news. It is not part of the news. It is not something that mobilizes the political will. And events such as this are spaces that are necessary to reposition the topic. We need to be prepared for the next pandemic that unfortunately is very, very near, very close to happen. So, without further ado, I would like to thank the invitation and the honor of being able to address you all here and the extraordinary opportunity that I have with everyone for the Colombian case, which is one of the beacons of learnings and lessons learned of the pandemic throughout these years. Thank you very much. Thank you very much, Dr. Zamora. All right. Next, we're going to have the representative of Brazil, Dr. Daisy Freitas Lima Ventura. She's coming via Zoom. Daisy is going to present maybe the most extreme case that we lived in politicization of the pandemic, which was the Brazilian case. Dr. Daisy, she is a lawyer, a PhD in international law for the Paris University, professor of ethics in the public health school in the University of Sao Paulo, the coordinator of global health and sustainability of the University of Sao Paulo. She has a fellowship of the productivity and the technological and scientific development. Her main topic of research is the situation of human rights during the sanitary emergencies at an international scale. Welcome, Dr. Freitas. John. We're going to adjust the agenda a little bit, but we're going to be able to comply with all the times, so don't worry about it. Thank you, everyone. Daisy, are you there? Yes, I'm here, Andrea. It is my pleasure seeing you here. Oh, it is a pleasure here. Welcome, welcome, Daisy. You can start now. Thank you. Thank you very much. And to Dr. Andrea Ramirez, I would like to thank all the organizers of this an important event. It is an honor for me to be here with you, even though I am, in a virtual way. With the time that we have, I would like to only give you a synthesis of the research that we've conducted between 2020 and 2021 was the research project for the mapping and the analysis of the juridical norms in response to COVID-19 in Brazil from the Studies and Research Center of the Health Care Rights of the School of Public Health in the University of Sao Paulo, where I am. I was one of the coordinators of this study that was actually performing collaboration with an organization, an ONG, NGO, a very influential NGO in Brazil, which is Conectas, and also with the funding of the National Council of the Ministries of Health of the states, CONAS, with the main purpose of recover the federal norms related to COVID-19 and to evaluate their impact in human rights in Brazil. Now, with the original intention of giving follow up to the impact of the response of the pandemic in Brazil with human rights, we ended up by discovering another thing, meaning the result of the research ended up by the difference for the federal part with COVID-19 that has been working between April and October 2021 with an immense repercussion at a national and international level. And this Senate research has not only been inspired with the study, but also with the supplement of the study that has been published that is available in both Portuguese and English, anyone that might be interested on it. So what we call timeline of the federal strategy for disseminating information about COVID-19 in Brazil was published in the first time in January 2021. And as I was saying, was updated per the request of the Federal Senate Parliamentary Commission. This study concluded then that in Brazil, we were having a diffusion strategy for or dissemination for COVID-19 promoted systematically at a federal level. The documented research was based on public data performed by an interdisciplinary team with different branches in public health, laws, political science, and epidemiology, having as a source the federal norms, the jurisprudence, the official speeches, the public manifestations of federal authorities, and the research of news in digital platforms. Now, the recollection of this information for this specific purposes of the study included the period of February 3rd, 2020 and March 28, 2021. And it was looking for information regarding events, actions, and emissions that had demonstrated the presence of intentionality of the acts and omissions of the federal government's understanding here as intentionality just as the confluence between the awareness of the omissions acts and the willingness of doing that. Now, the research has allowed the identification of three different types of tests. Number one, of normative acts adopted in the federal part, including the the presidential vetoes by the federal and general cameras. The second type of test, government acts that include actions of obstruction of measurements of contention for the propagation of the disease that had been adopted by the different local governments. The omissions related with the management of the pandemic at a federal level, and other elements that allow the comprehension and contextualization of the acts of, and government acts. And the third type of tests and evidence, the propaganda against public health that we have defined as the political discourse that mobilizes arguments at an ideological, moral level, such as fake news, without scientific evidence, with the purpose of discredit the sanitary authorities and to promote the political activism against the public healthcare system necessary for containing the propagation of the pandemic. With the relationship established between these three types of tests, we found out a confluence, a very evident confluence between the normative, management, and speech aspects of the general aspects of the pandemic with the coherence between what is being said and what is being done. That is very important because people that are following up in a very superficial way what has happened in Brazil, they have a trend to say that the government, and particularly the president who has been defeated in his attempt of re-election for the president of the Brazilian Republic. A lot of people has been thinking, a lot of researchers of many other countries have been thinking that the president was actually giving a speech for his more radicalized basis of support, which is notably anti-vaccination, who are opposed very strongly to the preventive measures as the use of face masks and the use of restriction of circulation that have been necessary in some parts and at some points. So we created this fantasy that the federal government had a different speech with their supporters, but with the practice, we had a different management of the pandemic that was limited, but had the intention of containing the propagation of the disease. In our study, particularly by joining with the official documents by the official journal of the Union, we made a difference of what the government was saying and the government was doing. This hypothesis that we didn't consider at first, but we defined it after April, May 2020, that the federal government conducted a strategy of diffusion of the disease can be identified in the different acts of emissions. First, the defense of the herd immunity by contagion or by transmission as a way of response against COVID 19. The federal government disseminated the belief that this natural immunity, which is derived by the infection of the virus, will be able to protect the individuals and will take us to the control of the pandemic. And for that, the government made different estimations without, not founded for the number of deaths and the date of the end of the pandemic. Different authorities. And another result of our investigation is that this strategy is goes further ahead of the government of the figure of the president of the republic. There is a set of authorities, and even all of the authorities and the members of the government that put in or were criticizing this strategy were removed from the government or even were part of their functions. We were giving cases of people that have been appointed to give functions, for instance, in the Ministry of Health, but by doing a criticism for that strategy, they were removed very swiftly. Then they actually haven't even been able to take their functions back. A second very important element is the constant motivation of people to be exposed to the virus and not to comply with the basic sanitary issues based on the negation of the severity of the disease and the apology of the courage of the people exposing to the virus and evidently the supposed existence of early treatment, quote unquote, for COVID 19. And this early treatment was, of course, turned into public policy conducted by the Ministry of Health and other governments of the federal government. Third, the banalization of the deaths and the aftershock and aftermath caused by the disease, and by propagating the idea that only the elderly would die, or people with comorbidities would die, or the people that haven't had access to the treatment or the early treatment that never existed actually. Fourth element, the systematic obstruction of the contention measures promoted by the governors and mayors, justified by the supposed opposition between the health protection and financial protection, which included the idea that the quarantine purposes cause more damage than the virus itself, and that those contention damages will cause hunger and unemployment and another pandemic. Another important element of that strategy was the emphasis on the federal government in the measures of assistance and the abstention of the prevention system of for the disease. For instance, we haven't had any federal campaigns and communication in favor of the vaccine or for the use of masks or for the adoption of preventive measures. And it is very necessary to clarify, particularly to those researchers and the foreigners, the foreign colleagues that are interested in the Brazilian response against the pandemic, it is important to underscore that some of the measures that have been adopted by the federal government have been by the obligation imposed by judicial decisions. The Supreme Court has obliged the government, for instance, to present a vaccination plan for COVID 19 or a protection plan for the population, for the First Nation population, etc. We're talking about hundreds of decisions, or even pressure of the National Congress that has eliminated a very important number of vetoes that the parliament has adopted for the protection of the population. The president has vetoed, and then the National Congress has been able to reverse that veto and to put some government, some protection measurements. So when the government operates in favor of contention, they operate under the pressure of different parts and further ahead by the valuation and electoral evaluation that, for instance, the Brazilian population wanted the vaccine against COVID. That probably would be something very interesting in an election level or for the position of the vaccine, even though the public of the main audience of that speech, the president of the republic and other authorities, can have, and sometimes, and some weeks before, they can put in doubt the efficacy of the vaccine and the effects that they can cause in healthcare, especially in children, something very severe that has happened in Brazil. Another element is having the systematic attacks towards the critics against the federal response, the press, the professional journalism, evidently to us, scientists, questioning the scope of the disease. Always throughout the period of the pandemic, where we had the creation of false controversies about the information related to infections and deaths. And finally, the clear consciousness and awareness of the authorities of the irregularity of certain conducts, because throughout this throughout this period has been conducted for administrative parts, it has actually been appointed, and those authorities have been based on their immunity that are linked to the positions of the mission that they have for protecting themselves of those against those judicial lawsuits. And even though this is not exhaustive because we have a little time, I truly believe that it is important that we need to underscore that the merit of this timeline has been offered, offering the actors, particularly in January 2021, when it was published by the first time, a general vision of a process that has been lived in a fragmented way. And with that, we have contributed to dissipate the persisting interpretation that we had inefficiencies or incompetence or neglection on behalf of of the Brazilian government for the management of the pandemic, when, quite the contrary, the systematization of the data, and I say in the majority of the official data and official speeches and discourse of the authorities, reveals a commitment and an efficacy in favor of the ample diffusion or the communication of the virus, even with the different transmission of the federal government, even in the most difficult part of this. It was actually the physical, personal dissemination of the disease in huge agglomeration that had happened only in the palace of government, for instance. We're talking about 40 mass events in the most difficult parts of the pandemic in times where not only we haven't used, they were not using the masks, but there were, I mean, the press, the people going there were encouraged not to wear it. Actually, the president was, he teared the mask of a girl as a signal that the population shouldn't be using this preventive measures. Quite the contrary, they need to expose with courage to the virus. Now, the main purpose of this strategy of dissemination of the virus was clearly to restart the economic activity as soon as possible in the territory, while by the tribunal configures the political option of the center of government to prioritize the protection against the protection of the life and the health. That's the conclusion of the tribunal that fiscalizes the accounts of the union that has been very active throughout the pandemic, unfortunately without success, in denouncing the strategy. Finally, it is, as a conclusion, the persistence of the behavior of the federal authorities in Brazil against the dissemination of the disease throughout the territory. And even with the quick increase of the number of deaths, meaning the government was persistent, even though the thousands of deceased were multiplied, and not only their catastrophic results, but also the work of institutions like the Superior Federal, the Supreme Court, the different entities, the scientific entities, the social entities of the healthcare system and other sectors, the management of the local governments. Nothing was enough to change the position of the government. And this commission of research of the Federal Senate that I have cited at the beginning of this very short exposition concluded the work in October 2021, indicating the need of researching the President of the Republic and other federal authorities of the crimes of epidemic with results of death, infraction of the quackery, incitation of crime, falsification of private documents, different crimes of responsibility foreseen in the Constitution, which is part of the impeachment, and also crimes against humanity, and in particular against the indigenous populations, but also in a real way and in a general way, it was concluded that in the sense of the Statute of Rome created by the International Judicial Court, it was created a systematic attack towards the civil population in Brazil. We hopefully now that we change powers, these processes can be moved forward and that it is perceived in a clear way, in a more effective and more expressive way, what happened in Brazil during the pandemic of COVID-19 for this to never happen again. Thank you very much, Andrea, for the opportunity of presenting this research. And I'm here and I want to listen to the rest of the colleagues that are going to talk and those that have talked before me. Thank you so much. Thank you, Daisy. This is extremely interesting. I'm going to ask you to please remain online and we're going to move on with the panel. Thank you so much. Well, we're going to move forward to Dr. David Bardet, who is going to be joining us and talking about the influence of the social context and economic context in the region and the management of the pandemic. Dr. Bardet has a PhD in economy, a professor of the School of Economy in the University of Los Andes. As an associated research of the Toulouse School of Economics, he works in topics of public economy, health economy, social protection, industrial organization and regulation. He has been consultant for the World Bank of IBD, UNPD, CEPAL, and the Ministry of Health and Reproduction Social in Colombia, and the Superintendents of Health and the Pan American Organization of Health. Welcome, Doctor. I can start by thanking Andrea, Rashid, and Silvia, and everyone here in the organization of this day. I think it is very important to do this balance about the management of the pandemic. As a matter of fact, due to time constraints, I'm going to be focused on two topics. First topic, non-pharmacologic measures, which is the name, a sophisticated name that we're talking about different parts, and I'm going to be talking about the vaccination policies. About the first aspect, I would like to clarify that I'm going to be a little bit critical about the management that we had for the pandemic. Critical in the sense of not a negative critic, just because to critic, just with the critic itself, thinking in the future, just in case we have some other pandemics in the future, and about vaccination. I think that quite a contrary, Colombia has been doing very good. We had a more positive balance here. Now, talking about quarantines, and with this, the first one was social distancing was at first installed for avoiding the dissemination of the virus. We know, and the main debate was to what was the optimal date to start confinement. The earlier, the better, or not. And that, of course, takes us to a more technical question about the effects of confinements. If confinements are only for delaying the peak of contagion coming over, or maybe obtaining, getting more time, or to putting the healthcare system ready, or if we can delay or to flatten the peak, maybe to having a less high peak, and maybe to avoid the congestion of or overflow or overcrowding of the hospital system. As a matter of fact, even the epidemiologists are not much in agreement between them. As a matter of fact, the experts in the university, when we're talking about it, always in the simulations that we had, only the first part to delay the peak, right? We have a higher peak, and there are other epidemiologists that they were talking about both effects to delay and to flatten the peak, and we can see that has a response to these answers. It is very important to determine if we need to take the better decisions or not. First, I want to remind you the problems of the governments in general, not only in Colombia. And then I'm going to go and talk about the case in Colombia. I believe that we have a wrong reading of the precaution principle. In 20 years that I've been working in this topic, and those who work about this or who work on this generally will try to underscore that we apply the principle of precaution when we have uncertainty or when the uncertainty is multidimensional, where it's not going to be restricted in one single dimension. And I really think that if we had a bad or a wrong mission, we only had not only the Colombian government, but also the rest of the governments around the world. We had an undimensional rating of uncertainty, which was the first one. That is, that is coming over to us in terms of virus, how contagious it is, how lethal the virus is, and the other dimensions, which is how much time can the pandemic last? If I'm not wrong, we're still in the pandemic, and if we have one or several outbursts, this is how we were doing, how we approached it in February, March 2020. There was only the only thing that we were thinking about is that the virus is coming, and uh, and when we forget about this, if our interventions are confinements, we're forgetting about the fact that a very fundamental variable, which is resilience of the populations and of confinements, meaning how long can people stay confined and how long the economies of the countries can resist with these confinements. And typically, the variable that is not contemplating the epidemiological models is the resilience stock of the populations, because that is fundamental to know exactly when you should confine the population. I'm not going to give you a discourse against confinement. I think that in the time of confinement, these are completely necessary. The question is where to do it, or if we do it in a necessary time, and if we need reopen in the worst moment, we need to make this topic more severe. We're not resolving this. And we can say that this reading of the precaution or the unidimensional part, we can see that implicitly the governments were in a competition and the most strict were going to be taking measures. Why would I say that? I say that because at the end of the day, the governments at this point only needed to respond for the COVID deaths. All the other deaths for not having the treatments in time, for not having the diagnosis in time, or for receiving not a very good attention. I'm going to give you an example that I just got to know in a very close way. In April 2020, I don't know if we had maybe 100 cases in the country. In Neiva, someone who had an open heart surgery, they bring them back home 12 hours after the surgery. The person died 5 days later because they didn't receive the attention that they needed. I give you this example because always the statistics are all kind of cold, and we forget the fact that we have very severe cases and dramatic cases that happen and that go through this. So the governments, the only thing that they need to do, we need to justify themselves. There are a lot of websites that you can find online when you can measure the performance of the different governments against the mortality of COVID, but we forget about all the other deaths. Now, in Colombia, first, I will have to say that in Colombia, at some point, it followed the recommendation of the World Health Organization, and I guess that there were not appropriate documentation. The context to remember it is that Europe was living very complex moment. I guess that everyone remembers March 2020, the images that we were receiving from Italy, from Spain, that were very alarming, and also the virus arrived later on to the region. So we had time to prepare ourselves, and I think that after applying the recommendation of the World Health Organization at this point, we actually had early confinement, horizontal confinement, a little bit of a copy paste of what was being doing in Europe, and therefore, and I think, and I'm going to show you why I think, we had a very early confinement. Of course, we needed to prepare the healthcare system, and at the end of the day, and actually the minister was showing, I think that it could be done in a faster way. As you know, the hospital has, it's not about the mathematics, it's not the number of fans or a number of ventilators for the ICU capacity, is the number of intensive care specialists. An anecdote, a little bit of a sad anecdote, when we have this fight with the governments for the delivery of the ventilators, the next day, on the Twitter of the district that were looking for intensive care specialists, they realized that they needed the fans, but the fans were not working by themselves. And I suspect, and that is a suspicious with a very much educated guess, that many of the ventilators were not able to be used because we didn't have people in the hospitals that were able to put them to work. So that's why I think that we had a very early confinement because we needed to reopen in the worst moment. Maybe we can see this here. We starting at the beginning of the we started the confinement at the beginning of the marriage. We wait until Rashid got married, and then we got confined. And then we have a partial opening around May, the second half of May. And then we have a smart opening. But then you can see here what we did in these first months. The people didn't see anyone. All the families were not visiting anyone during 2 or 3 times where we have very little cases in the country. Then the government and the economy was not able to withstand. So we reopened at the beginning of the exponential phase of the contagion, which means that instead of minimizing the contagion at this point, we maximize them. Obviously, after what I'm saying, this could be applied what with the economists can tell with the critics of Bekele. I am saying that the peak arrived way later or later because we actually were confined. So I'm not saying that confinement was not useful. Of course, we needed the confinement, but we needed to let the virus circulate a little bit more in the country to avoid and then to go in confinement where we could estimate that we were able to reduce the saturation of the virus for the congestion to avoid the overflow of the hospital system. We were saying it is not a propaganda, but we were doing this at this point for them not to say uh, that I'm not doing these positions after that. That was on May 8th, 2020. And I truly believe that the decisions that were taken were by a wrong reading of the situation. Carlos Arturo was the doctor start of the government as an advisor. And we were in the middle of April, in mid-April 2020. Carlos Arturo was thinking that the pandemic was about to be over by the end of March or April. It's not to criticize Carlos Arturo. At the end of the day, everyone was wrong. Everyone was wrong, actually. Politicians, epidemiologists, and at the end of the day in Colombia, we were waiting for the peak. We were impatient for the peak to arrive because we were overflowed in the healthcare system, and the peak never arrived. So we were first we said May, then June, then August, and then we're still waiting for the peak in September, and we didn't get it. It was not quick enough. So I just put the disease curves. I probably could have put the disease at the end, and this is just a curve by multiplying in this factor. But I think that, as a matter of fact, we overinterpreted the principle of precaution with a unidimensional part, and we didn't ask ourselves how much time this is gonna take. Me, for example, that I talked to epidemiologists, these models where I've been doing this for 15 years now, and I also talked to virologists. And when I talk to the different virologists, I've always been saying, oh, there are some assumptions that we don't have any idea of how to fill out the parameters of these models. So I really think that at this point, we've been uh, giving a lot of attention to this and importance to these epidemiologists, forgetting that we have assumptions by which we didn't have any information because this is a novel virus, so it is quite difficult to do predictions. Well, about vaccination. it was a miracle to have vaccines very early and also with different mechanisms for the application. I think that we had a very unnecessary noise around the prices because at the end of the day, a lot of economists were calculating that the return of investment in public administration has never reached in any country. I guess that there was a debate that was very wrongly presented when we have bottlenecks at a level of production. We were talking about the lack of coordination, a little of the countries that didn't have a peak on time, so we were figuring out a worldwide governance to try to send the vaccines were needed the most at any moment. But I really think that there were some wrong messages about the pharmaceutical industry. Let's say that patents was not the solution to comply them. I guess that probably a better way would have been worldwide governance to purchase the patents and try to break the bottlenecks than fighting with the pharmaceutical industry, or even more with the different variants. Because if we needed to adjust these vaccines, then we needed to for the industry to work, to walk, and to work with the different systems of health, not against it. What it is a little bit fun or strange is that the vaccines were solved with the prevention system of saying, oh, I need to have a vaccination, we're going to have a lower capacity of getting infected, or I wouldn't infect as much to others. But at the end of the day, what we are observing after different variants, much more contagious, is that the vaccination was more of a secondary prevention aspect. If you get the disease, you infect the others, but we have a less severe effects, which creates a positive externality for the system because for having less severe effects, and that contributes of not overflowing the ICUs and being able to, of course, trying the most severe cases in better conditions. Now, about the vaccines in Colombia, I think that by considering the legal restrictions that we have, for instance, in Colombia, with the ES, but in particular, we're going to purchase vaccines that didn't exist because at the end of the day, the project was going to fail. So that was going to be a bad investment on behalf of this. Colombia participated in the COVAX mechanism. They made bilateral purchases. And I think that the vaccination in Colombia was a little bit more, as in France, with a slow start, but then we achieved a very good speed for the coverage of the vaccine. And then, in addition, I would like to stand out that there are several projects in different stages to go back and to start manufacturing vaccines again in Colombia. And I think that is an excellent decision. I guess that we need to be more independent in terms of we're in the healthcare system, and I truly believe that we need to move on with this. Now, about the different figures, I guess that Fernando left, but I don't have the same numbers in terms of mortality when we compare this with other countries. As a matter of fact, Colombia, as I was telling you, there are a lot of countries that are coming together. There are countries that have this that are smart enough to divide it into the number of inhabitants. Colombia, at the end of the day, is in the top 15 of the countries with the highest mortality. due to COVID. And I really think it's something that we need to analyze later, not only to look at the mortality of COVID. We could avoid all the deaths that could be avoided, all the additional mortality that we're going to have, not only due to COVID, but also by the effect of some other measures. And I truly believe that with this, Colombia has a young population compared to other countries. So we didn't have as, that makes us we have better results. And that was the main purpose of preparing ourselves with the future pandemics. Hopefully, we won't have, no, but yeah, we never know. My recommendations would be to have a more multidimensional approach. I think that we had an obsession with these curves of the epidemiologists. Of course, they were very useful tools, but we were having a lot compared to other, like a novel virus that we don't know. We were having a lot of uncertainty about different parameters for focusing ourselves as we were being focusing with these curves. We need to talk to virologists. I think that at the end, we're saying, okay, the economists, sociologists, they don't talk about enough with epidemiologists. Something that caught my attention is that epidemiologists didn't talk to the virologists that much. They were actually the ones in charge of knowing the viruses and how the virus could work and the implications that that could have over different situations. Also, in order to know when to confine the population when the virus gas, um, maybe the resilience for population is fine. Also with the economists, also to say how an economy with a population with a confined population can withstand. We need to have a more multidimensional approach for the future pandemics, and not only to be focused on the curves of the epidemiologists, which are useful. I mean, I'm telling you that, but we need to give you a context. Also, we need to consider the idiosyncrasy of the countries. Also, to follow the recommendations of the World Health Organization, we copy pasted. It was the WHO who provided that without considering the fact that European countries or Latin American countries have very different realities, especially in the labor market. In what we talk about the informal sector, we cannot confine in the same way the people here compared to the European countries that we need to be that everyone is an administrative worker, right? I mean that we cannot receive it. We need to have more 60% of the salaries, for example, in France. The government was able to pay 60% of the payment of the population, and we cannot do it with an informal sector above 50%. We need to adapt ourselves with the politics, but we need to put a framework that works very similarly in developed countries for developing countries. So my conclusion would be trying to have a more. We need to see what we can copy. We need to filter. For example, the track of the virus in Israel was something amazing. They actually put they actually use the police to track the virus, but there are things that we cannot copy. There are things that we need to be more creative at a local level and not to receive all the recommendations coming from outside. Thank you so much. Thank you so much, Dr. Barte. We're going to move on to Dr. Francisco Gomez. I'm sorry, Dr. Ana Maria Vesga from the National Association of the Entrepreneurs in Colombia. She's going to talk about build multi-sectoral alliances to face the COVID-19 pandemic challenges. She's going to talk about the case of the Empresas por la Vacunación, companies for vaccination. Dr. Ana Maria Vesga is the Vice President of Health in Andes. She's a lawyer from the University of Los Andes who's also conducted studies of high direction and strategic leadership. She has a lot of experience of entrepreneurial strategy as well as the management of projects in different sectors, such as mining sector and pharmaceutical sector. Welcome, Doctor. Well, thank you. Thank you so much. And I would like to thank everyone for the former Minister Fernando Ruiz, who actually did something, bringing the information that I wanted to share with you around the numbers that support the response of the country against the pandemic, particularly to what has to do with the increase of capacities. So, I would like to be more focused here and to explain you why we wanted to bring the case for the companies against vaccination. Then, when we were sitting with Andrea to see which were those experiences and to see the cases, the success cases that we wanted to present in the experience of what we lived in these years and remain for the future possibilities of a correct public and private articulation. This is one of those. I think that one of the things that we saw as of today and the experiences that we've been having for today in other experiences and the response on the pandemic, they address for the capacity that we have and also for mobilizing everyone in an articulated way and with the extraordinary disposition of resources that made it possible for that increase of capabilities. I'm going to go through with some numbers that the ministry can have that are no lower, but what happened with the effective coverage of health with very important measurements in the framework of the emergency that increased the capacity, that increased the country in 99%, and with the installed capacity for 5,000 to 13,000 for the laboratory for the diagnosis tests of 1 to around 227 and the amazing effort. And we have to tell you that Dr. Masta Ospina is here that was able and possible in terms of coordination from the National Institute of Health with the laboratories with the rest of the countries, not only for taking the tests, maybe that was a simple part, but actually to receive it, to process them, and to have trustworthy information that we saw as in different countries. This is a time that we actually don't, there are countries that don't know the truth with the pandemic that didn't happen in Colombia because we did something to articulate the information around with the different labs in the country. In terms of telemedicine and in-house attention, we have an exponential jump. We actually came 10 years ahead in the transformation of healthcare. We were barely talking about early stages of telemedicine. The country fivefolds its capacity, and it gives around 195 million of attention. The different types of attention, not only in-house attention, delivery of medications, laboratories taken in house, orientations in health and teleconsultations, and this represents to the country an extraordinary attention, and it poses a great effort for the rendering of services of IPS for telemedicine. Of course, with a great challenge, a grade of connectivity that the country has, and in spite of that, we achieved to that number. In terms of wealth and technology in health, I think that we have some great topics. The first one, and we have Leonardo here, what the country did for the sufficiency and delivery of medication. It was a reality for this, for the principle of acetaminophen for the exports. It closed the situation and against the world of having acetaminophen. So what happened, for instance, when we were talking about the hydroxychloroquine as a possible solution for COVID-19, we were actually closing to see in import and exports of that. So it was a correct articulation between the Ministry of Health, the producers of drugs, the importers of drugs, allowed the country to stop the lack of supply. We were talking about the different medical devices in hospitals, and not only talking about the supplies of oxygen. Ingrid Reyes is here. She is the director of the Chamber of Gases and Oxygen of Andy. There were days that only had like hours of oxygen left to the country. So, how we were able to give a response? Well, only by an effort of the industry that was able to multiply its capacities and to deliver what the country required for the attention of their patients. This was, of course, due to an institutional effort and by addressing amazing resources. The Minister Ruiz mentioned it. We created the FOME. In the framework of that FOME, we're talking about 15 billion Colombian pesos that we put in proportion. We're talking about the 80% of the fiscal reform that we're going through right now, or the fiscal elements that we have here for the country. 15 billion pesos for the pandemic. Now we're testing for the assurance, and as we were saying right now, this concept of assets for emergency that arrived to the coverage of the around 79% of the population that allow us to do an extraordinary effort for giving hospitals and to condition hospitals for the intensive care units that allow the acquisition of vaccines, and of course with the different subsidies and assistance and social attendance that occurred during the pandemic for Professor Bade to allow it, these long confinements that we lived during the pandemic. Another point not less important, out-of-pocket expense. Look at the percentage of the out-of-pocket expense as a GDP percentage compare among countries with similar economies with populations of different sizes. What happened with Colombia for pre-pandemic 7.6 as GDP and an out-of-pocket expense, a lower out expense. And what was the reality of our country? In our country, the people didn't have to sell their houses, their car, to take their patients for weeks for intensive care. That didn't happen in Colombia. So that effort of the government for destining the extraordinary destiny of resources, but it's particularly and very importantly for our healthcare system, for the assurance that it was conceived and the financial protection as it was conceived. We obtained that to obtain an out-of-pocket expense, the lowest, one of the lowest in the world, not only in the region. So I'm talking about Empresas por la Vacunación, companies for vaccination. It was led by Andy very, very early when we started the conversation about vaccinations. And we were discussing about if the country needed to purchase vaccine through COVAX mechanism or if it should be go in the bilateral conversation with the laboratories. We as a country had several legal restrictions that limited the acquisition of the different vaccinations in the experimental vaccination, such was the case for all the vaccines that more than 90 projects around the world we're talking about in phase 2, in phase 3. But as a matter of fact, we were purchasing uncertainty, and the country had a legal limitation in the acquisition of those vaccines, precisely because giving resources or public resources for the purchase of experimental vaccines was forbidden. So the entrepreneurs in the conversation and in that false dichotomy that is presented that if either health or economy, they start to think, okay, well, we as a production sector of the country, we cannot have the benefit of staying here. If we're going to have vaccines or we're going to acquire vaccines, in solidarity, we would like to contribute with the national plan of vaccination to acquire vaccines for our employees and to make sure that the reactivation at companies is given in an earlier way. Why? Because we needed to move the economy around. So then we have this idea of companies for the vaccination. Andy calls a group of different sectors. We have the national sectors, and not only for the national sector, but other sectors, small sectors of different sectors, where at the end of the day, we have more than 2,127 companies joining in. And we have the Ministry of Health, and we say, okay, well, we want to purchase some vaccines. Of course, this was breaking a paradigm, breaking an essence for the attention of public health. Who are the ones in charge of vaccination? The states. Who do the vaccination? The states. Who is in charge of applying the vaccination? The state, right? I mean, the government was in charge of starting the network of hospitals for applying the vaccines. A lot of the hospitals were not even able to do it for the vaccinations. They needed to increase their capacity, and we have a lot of questions how to do for a private initiative to do it for not to be unequal in regards or compared to the plan of the government, how to stop the privilege of certain populations versus the vaccination towards the national plan of vaccination. And of course, we were having some tensions. And of course, and such as in this, the public and private articulation supposed coming from the confidence. And the entrepreneurs have never acquired vaccinations and never applied any vaccine. So I can understand that for the Ministry of Health and the authorities was a little bit risky to think that a private sector was able to put available the resources and to acquire the vaccines. So what would happen with that vaccine? What would happen with that? What would be the consequences in addition of applying a vaccine that at the end of the day was in an experimental phase? The good thing is that we were able to design a mechanism, and for this, we need to say that the presidency of the Republic enhanced with the administration department of the presidency. The President Duque thought that this was possible, and he actually instructed to do so. We were able to articulate with the Ministry of Health and the National Risk Management Association this mechanism, which was the first program of vaccination for entrepreneurs that applies vaccines, that applies the vaccine of more than 1.5 million people. What were the conditions? This should be solidary. This could be supplementary. This couldn't be a competition against it, meaning if the government or the Ministry of Health were vaccination between 50 and 60, 40 and 50, 40 and 30, etc. We as a private plan were not able to vaccinate people below that age. It should have been made in a coordinated way. We weren't able to do it, and this was a restriction. We were not able to use the same capacity of the government. That not, of course, I mean, the government was very clear to say, don't use my IPS. But hey, I mean, why we're not going to be able to do it? Don't use my IPS because I need to destine all my capacity to a national vaccination plan. So what that represented to create a network outside of the IPS that we're working in the national government and to make sure that we can disseminate or to implement that capacity throughout the nation. Of course, we were not able to have costs for the Colombians. Of course, I shouldn't be able to have a cost in the private part. What does that mean? That the entrepreneurs needed to, out of pocket, acquire the vaccines and no financial benefit. All of that require a legal framework that starts from the vaccination law, the 2064 law, that allows not only the national government of acquiring those vaccines in an experimental phase, but after that we have the full development for the 840 resolution to have the different requirements for the private sector to acquire and apply vaccinations for the national vaccination plan. All of that structure happens in a framework of around 6 to 8 months. But once again, that gives us the vaccination sustainability to create a vaccination mechanism that would attract and for somehow to make sure the companies to allow to deposit the money. The National Entrepreneurs Association, of course, was with those companies, but it was not for more than 1,200 companies that didn't even know what Andy was. So, how we're going to be able to gather that in private sector by warranting the correct management and transparency and traceability. So, what do? We did a strategic alliance and we acquired through the government 2.1 million doses of the Sinovac vaccine for the bilateral vaccination acquired by the Ministry of Health with Sinovac. We enter into some adherence contracts with the companies, and we organized. I mean, based on that, we received the resources for the entrepreneurs, and we organized the reception, the organization of the network, and the vaccination. We need to say that in 3 days, this mechanism gathered more than 300,000, that 300 billion Colombian pesos. We never thought that that would have that capacity, response capacity. We got organized with the Santo Domingo organization in a technical secretariat and with information bases that would allow companies to go into a platform to look at the population with the region, and that would allow us to have a benefit network that was present in more than 700 municipalities. As you can see here, throughout the regions of the country with a prevalence in Dinamarca and Boyacá with more than 45%. But we actually reached even the Amazonas, that through some industries that never had an industry with their own network, but that were able to articulate in a very efficient way. And finally, this is a result. Out of 2,100,000 vaccines applied, we applied 1.4 million vaccinations. Why we didn't achieve the goal? Because the national vaccination plan was accelerated. We receive other countries from Moderna, Pfizer, AstraZeneca, Janssen, that are a little bit of resistance to the Sinovac vaccine the first couple of days. But we found that the people that coming over to vaccination in the private sector had in the next the possibility to get vaccinated with Pfizer. A lot of them chose Pfizer against other vaccination, but we had a remaining of about 500,000 vaccines that at the end of the day were it's being donated to a national vaccination plan. We applied and we reached 70.5% of compliance. We are talking about 702 municipalities and covering 78% of the country. We enable a network of 54 IPS, and this is a very fundamental support of the compensation boxes. Many of those enabled with vaccination services for vaccination, maybe some other out of the box that were committed with the project. And the companies realized 237,000 million pesos. What, why was that possible? Because the private sector reacted. reacted in a promptly way, but also because from the public aspect, the government was willing to make this alliance possible. This is simply a message to think what everything is possible when we articulate and when we talk about the missions, you can think about our countries with the opportunities and the needs of closing gaps are very important and they're persisting, and the importance of, maintaining a correct articulation between public and private parts, not to trace line distance and to think about what is possible with confidence that get together too with the same objective. I leave you with this brief video and thank you so much. The initiative Empresas por la Vacunación is the result of a solidarity effort of different industries and led by Andy to support the vaccination plan of the government and thus contributing to save lives and to accelerate the reactivation of the country. More than 1.5 million doses have been applied to workers, families, and population of different parts of companies, showing the strengthening of the Colombian entrepreneurship and the commitment with the country. I'm very happy and I see a growth with the company. That's why, for the efforts of that, and I recognize the company so we can be vaccinated to those that every day are here to move forward and to help the company for all the purposes that they want. Thank you very much for that. As of today, in the moments when the company was stopped, 2,927 companies of different sectors jumping in this initiative, and hundreds of workers worked with happiness and hope. My name is Joaquin Garcia. I'm the commercial team of Celsia Company. I decided to have a vaccination here because I am to have peace of mind. I feel valued by my company. That my company worries about me. We need to work with this. My name is Jessica Paola Padilla, and I'm a professional for Prestas, and I am very happy to be part of this vaccination program for the well-being of everyone. An APS network in 26 apartments adapted the capacity to address this process of vaccination. Well, we were thinking that this is not talking about the operation, but what if the workers are okay and to think about the families. My name is Diana, and I am very thankful to Ultrasim to give the opportunities to the employee for the relatives to get vaccinated and to avoid the contagion of COVID-19. I'm very thankful for this. And thank you to Andy, and thank you for to all of them, entrepreneurs, industry, compensation boxes, and IPS. We want to recognize everyone because this effort saved lives, protected families, reactivated companies, and demonstrating that when we work together, we are more of a country. Thank you very much, Dr. Vega, for your intervention. We're going to invite Dr. Francisco Gomez from the Santo Domingo Foundation. Can you hear me? For him to talk to us about the private investment in health, accelerating the tools for the handling of COVID-19 in low-income countries. Dr. Gomez is the program director of the Santo Domingo Foundation, where he leads the development strategies for education, healthcare, and the environment. He was the subdirector of the services for the special projects at the Biological Resources Alexander von Humboldt and director of environmental affairs for the Ministry of Environment and Sustainable Development. After the intervention of Dr. Gomez, we're going to have a small discussion and then we're going to have a break because I know you are a little bit tired. Thank you very much for this patient. Dr. Gomez, thank you. Good morning, everyone. I want to take you throughout the history of what we have in our work in the Santo Domingo Foundation, mainly for how we adapted all the intervention adaptation that we've been developing by the moment that when the pandemic arrives. The Santo Domingo Foundation is a foundation with more than 60 years and with a purpose. And the main purpose is for more people to provide well-being to their family members and to make Colombia a more equal and sustainable country. This is a great purpose. This is very ambitious. But after having a purpose such as this one, and in a situation as we had in 2020, well, the most logical thing is for us to have the flexibility and, of course, to be fast enough to act in the support for this. We have four main work lines. One of them is territorial development. The other ones are education, health, and the environment. The developmental aspect gives us a work environment from the geography, from the scale. In the territorial development, we have some macro projects of residential macro projects, and what we do there is we try to provide a comprehensive intervention of urban development, economic development, funding, and entrepreneur, and in the construction of community and citizenship. The main idea of the programs of healthcare is to arrive to those territories and to start working and supplementing all the offers to create well-being and to comply with that purpose. When we arrived in 2020, we started to design everything that is supposed to be from our actions in these logics to be able to support everything that was necessary, but mainly thinking about those factors, not direct factors, but let's say like second impacts or impacts of second order in the population. We were able to build a strategy that led us initially in three different topics. In short term, it was an emergency action, immediate actions, and that was mainly focused on healthcare, food safety, and well-being. It was a little bit clear for us to see where the public policy was going towards in terms of confinements, and I think that the well-being aspect is one of the most impactful. I'm going to show you a little bit about it. The idea was that at a medium and long term, 2023, to adding up education, environment, and economic reactivation topics, and maybe decrease some others such as food safety. And at the end of the day, the investment of resources that were made available for the country for the pandemic were around 100 billion Colombian pesos that and we're going to finish with that by next year. I'm going to jump ahead on this and I'm going to talk to you a little bit in detail what is it that we did in the main purpose, in the main topics. Now, in topics, we were focused on trying to support the healthcare system, trying to support the healthcare providers and the personnel in all of the regions. We implemented a strategy that took more than 3.3 millions of personal protection equipment. We increased the capacity of diagnosis and processing of tests in around 500,000 tests. Ana Vesga already talked about the full plan of Entrepreneurs for Education, where we participated not only by contributing resources, but as a technical aspect on it. But we also supported the National Vaccination Plan in full with the application of around 1.7 million vaccination, including the Empresarios por Educación, and also by the foundation that was by the logistica part that were part of the state. We would support for the acceleration of the application, but we also work with the delay of the PI vaccination. That in this confinement on the youngest children. And finally, from our territory, we work in some programs of impact that is also associated with this second tier impacts, looking particularly to work with healthy lifestyle habits and sexual health and reproductive health. We reached 31 departments. We worked in more than 154 municipalities for the prevention. And as I was telling you, 500,000 tests, more than 450,000 have been right here in processing. But we also worked on the topic of the oxygen supply, the oxygen network, and well, everything associated to campaigns for treatment with 29 institutions throughout the country. Now, in terms of vaccination, this is a little bit of what Anna talked about. We worked in two main topics, one of them in our territories of influence. We worked with Vacunación Barranquilla, with La Vacuna es de Todos, De Una con la Vacuna, and Vacunación Atlántico, our main focus and our main approaches in terms of trying to accelerate the vaccination in these territories. And the Atlantic in general was one of the country's department who achieved the better results in terms of vaccination, and everything conducted for Empresarios por la Vacunación and the articulation that we did with the Valorem Group in order to support this model that you just saw. And in order to achieve that, at the end of the day, everything that we did was very well documented, that could be done in an agile way, and also understanding that this topic was a pretty much new topic for the companies that we didn't have the experience in doing so. Now, out of the things that we wanted to highlight was the main design of the communication strategy and the promotion of that strategy as well. Of course, the follow-up in terms of implementation and also looking for that the hardest places to reach from the state, that it was deployed in an impressive way or by us. We could facilitate that access. We could understand which were the populations with more difficulties to access and to try that our equality logic could actually being implemented. We had a lot of achievements. One of the most interesting parts here was the lessons learned. A little bit in how we wanted to work from the private sector to support by understanding everything in a trust relationship that each of the actors and the stakeholders they have their own role in this, and of course from the private sector all of the mobilization around public policies and how we acted during the emergency period, what we were able to do in terms of articulate a couple of companies that wanted to participate in it, who wanted to contribute on that dynamics of the economy and that wanted for this to be successful. Of course, the geographical prioritization for us, due to the latitude that we worked, was fundamental. And understanding that this should be done hand by hand or hand in hand with the territorial entities, with the local and regional governments as well, which are exactly the ones who understand the context of these specific geographies and who understand how we can facilitate those accesses and to use those contributions in the best way possible. And well, I guess that at the end of the day, it led us a lot of experiences. It left us a lot of experiences around the difficulties that these processes entail and what we could actually achieve in terms of technical implementation, logistics, and communication, etc. Porque quiero estar bien is, which translates to because I want to be well, was the interaction and well-being project that the foundation created. It was created around March 2020. And what it aimed was to be a follow-up program in terms of mental health for first aid, psychological first aid, that could talk about these second-tier impacts that we were supposed to have not only by the confinements, but also by the level of anxiety that we were living in pretty much around the world regarding the situation of this pandemic that we didn't lived before. And we designed it as a platform and for internet and for the digital channels where the Santa Fe de Bogota Foundation, for the personnel that we were looking for, and we wanted to for some tests of, for them to be able to self-diagnose, and of course, if we were seeing some sort of anxiety of stress present, we have a repository of information, like a library of information, some articles about mental health, about well-being, that could be opening these tools for the people who were looking for this type of attention. Now, the psychological orientation services that were focused pretty much on the first aid logics, and then some teleconsultation services, or when the main purpose was to do an attention for 4 sessions, therapeutic attention, and then we were looking for a way to channel those patients to their physician for the continuation of a treatment just in case it was necessary. As a matter of fact, the results were actually impressive. We were not expecting the success of such a program. We were more than 5 million. I mean, we were achieving more than 5 million hits, and we achieved more than 3 million users. And it was so successful that we thought that this program should continue. I think that the pandemic and the situation, what actually created was like, well, it made visible the mental health issues that were existing and that we worked in a hidden way. they became visible, and somehow those conversations about mental health got normalized, and this is a topic that for us is quite important in terms of the experiences and in terms of the lessons of our work for the last couple of years. And Porque Quiero Estar Bien is going to continue to be a program of the foundation. And hopefully, it becomes more important on terms of mental health, on the comprehensive glimpse on it, and a little bit of what we actually put together in terms of the people who were accessing. Maybe particularly women, 77% females in a age gap or an age group between 17 to 44 years, 25 to 44 years. The main way of contact was WhatsApp, 70%, and the main motive of consultation was anxiety. Bogota was the city where we received the most calls from, but actually we received consultations from Mexico, from Chile, from Spain. We also see that there are not enough tools such as this one for the population, not only in Colombia but in Latin America, pretty much around the Spanish-speaking world. Now, in terms of food safety, this was one of the first actions that the foundation was working on. We achieved 1 million people. We worked around 103 alleys. We reached 6 regions and 342 municipalities. We didn't only use resources of the foundation over here, but we also levered around 4.5 billion pesos in bilateral agreements, and we were able to deliver around 380,000 markets. I guess this was one of the most impactful emergency actions. This was one of the needs that were required the most, even understanding this context in our economy that Mr. Bradley was mentioning about in terms of informality, and that was reduced in 2020. This was a very great program. By 2021, we continued with it, and by 2022, it ended up, but the impact was fundamental for our comprehensive strategy. Now, once again, I guess that the main lessons learned were we considered the difficulty on it. All the food safety was tried to be linked in a with a topic of the ability of employment. Everything that has of the logistic associated to take this market and to select where we needed to be taking this, and it required a lot of hiring. And as a matter of fact, it was very complex. It was very difficult. This hiring was very complex in terms of requirements, of legal requirements with the population, of community leaders in territories, in very vulnerable territories, in where we have our largest influence. A lot of operational challenges. We were not only talking about a strategic design, a comprehensive strategic design with a purpose, such as food safety, but how is it that we could comprehensively respond as an organization from the legal aspect, financial aspect, administrative aspect, to be able that all of these challenges around this hiring were achieved? We also had a lot of lessons learned in terms of expectation that we were generating in these communities about the arrival of the supports and how and the role itself of a foundation, in this case, this foundation, the Santo Domingo Foundation, to arrive with actions that were pretty much for assistance, but, due to the emergency, that were pretty much necessary. We also worked in economic reactivation. The principle of the design of this strategy was to understand that the economical impact in our country in general were significant. Fortunately, this was something that was understood as well from the public policy, and then we were able to align ourselves with a full strategy of economic reactivation that was not only from the foundation, but it was at a country level. We also worked, this was mainly on the priority territories in the foundation of our territories of maximum influence and trying to build are not letting the employment and entrepreneurship systems to die that could let us help us out on the moment of crisis and then to project in the future with possibilities of growth. The entrepreneur development unit worked. This unit was actually part of the foundation where we had a soft credit portfolio and it worked in a very detailed way in a strategy to increase the probability of income or of collection by understanding the opportunity that our customers of this portfolio were having and by supporting them of creating payment methods that would allow them to keep themselves afloat and not to enter in a default. We also had a very important work around trying to reactivate the economy. One of the main projects that we had was the Caribe Exponencial project, where we were aiming to find possible entrepreneurships that would exponentially grow with that potential and to support them with an offering of strengthening in terms of entrepreneurship so we could actually develop that potential and that somehow would move the economy and made it more dynamic and to try to keep the works or even grow in the employment rate. We also worked with the community of the macro projects as well by identifying which were these main needs in terms of development and trying to take them throughout time by saving the most amount of employment, so by passing this time of crisis. In 2021, we transformed a little bit the strategy of the entrepreneurship development unit. We tried to, let's say, capture the wave in terms of that reactivation or economical reactivation policy that was growing throughout the country. And we actually grew the portfolio. We modified a little bit the composition of this portfolio to achieve or to reach the entrepreneurships and to offer financing opportunities to those that were interested and continue. We kept the entrepreneurship strength in terms of marketing and in terms of biosafety. And we had some other addendum or addenda around the reactivation, like the issuance of a social impact bonus, the approach of demand and supply by trying to connect based on the network that we were trying to connect between these small businesses and the demand. And of course, Caribe Exponencial continues. That was actually one of the programs designed after the pandemic and that yield very, very interesting results in terms of the projection of these startups that we are supporting for them to show actually that potential. Now, these are out of the programs that we conducted in terms of economic reactivation. Acupuntura Urbana, Urban Acupuncture. This is a program, it's a very beautiful program that we do in Villas de Sao Paulo, in Ciudad Bicentenario, and Baru, and has to do with a comprehensive vision of the territories We're trying to understand which are the most important points or hotspots in terms of cultural interaction in these territories to take something, well, a little bit of a modification of these spaces and investment infrastructure and a higher appropriation of these communities. And the most important part is that we do it with themselves. We train them just in case it is necessary for us to train them in some of the topics that we are trying to do in terms of works or application, for paintings, for whatever is required. And these programs are not only looking for bringing the people not only to the cities, but also for them to become owners and for them to understand the importance of their community, but also we try to reactivate the economy through these actions and these investments in infrastructure. And we are also working very hard, most of them in Barranquilla and Cartagena. Ilando is a program that we do with women in Villas de San Paulo, where we have a tailoring workshop that half of the pandemic was pretty much focused on creating masks, face masks, even at a hospital level. And at this point, they're working in creating a circular economy by creating uniforms with recycled materials from larger industries. And well, it's still working. And these are a couple of examples that are very successful in terms of what we were able to do in terms of economic reactivation. And well, finally, we wanted to thank you. We thank Ana Maria for the words that our healthcare manager was telling us at the beginning of this event. Juntos somos más, together we're more. And thank you very much for your attention. Thank you, Dr. Gomez. And before break, we are having a small discussion led by Dr. Gabriel Carrasquilla of 20 minutes. I'm going to invite Dr. Zamora, Dr. Carrasquilla, Dr. Ana Maria Vesca, Dr. Francisco Gomez, and we're going to have Dr. Miguelandi Torres from Zoom, via Zoom. I'm going to introduce our moderator, Dr. Gabriel Carrasquilla. He is a doctor, a physician from the Del Valle University, and a healthcare professional from that same institution. He has a master's on tropical medicine sciences, and he has a PhD of public health by Harvard University. He was a director of the Research Center of Salud 6 from the Santa Fe de Bogota Foundation. He has been member of the Healthcare Council of Awareness and the consultation or advisory meeting. He has been a temporary consultant of the World Health Organization, PAHO, Rockefeller Foundation, European Union, and the Ministry of Health. He is currently the Vice President of the National Academy of Medicine in Colombia. We would like to thank him very much. We also would like to thank our allies and the National Academy of Medicine for helping us with the coordination of this event. Dr. Leonardo Arregocés, please, we're going to ask him to join this table. Very briefly, I'm going to invite our two new guests, Dr. Miguelandi Torres, who is via Zoom. She has a PhD of public health, master in biomedical sciences. She's a specialist in epidemiology and she's a specialist on healthcare management services. She is the former Ministry of Health of Santiago de Cali. Dr. Leonardo Arregocés, he is a doctor from the Javeriana University. He has a master's on public policies and planning in health from London School of Economics. He has a PhD of public health from London University. He was a doctor of medications for the Ministry of Health and Social Protection between 2020 and 2022. He is currently working as a professor of the Javeriana University and advisor of the World Bank. Welcome everyone, and Dr. Barranquilla, welcome. Thank you very much, Andrea. And good afternoon, pretty much afternoon. Thank you very much. I would like to thank the university to invite the Academy of Medicine to participate in this colloquium that is very important. I guess that the pandemic hasn't finished. It's not over yet, and the analysis about the pandemic needs to be an ongoing issue with a lot of serenity, with a lot of depth, with a lot of demanding to be able to have the clarity about the lessons learned and based on the lessons learned that we had during this pandemic to be able to prepare ourselves to what a lot of the presenters have said for the next event of public health. And of course, and the academy is thinking about it. We're thinking about doing this analysis with a very select group of experts and leaders from Colombia and outside Colombia. That you're going to be receiving the information very soon. Also, with these great presentations from different perspectives, from the government sector, by former ministries, and the private sector, the academic sector as well. We're talking about 270,000 questions that you have to ask to the panelists and us with the organizers of the event and with Andrea leading it. We prepared a lot of questions to do it, but obviously we're not going to be able to do it. We're not going to have time to do it. And I'm going to just ask one question to each of the speakers today and give them no more than 12 minutes and 27 seconds for their answers. Then I'm going to let them know. And I'm going to start with the first question. I'm going to ask the question first, and then I'm going to say who's going to be answering it, so everybody could be prepared. The first question is, one of the things by which the vaccination process started, preparedness for vaccination for the pandemics, was with the announcement of the global announcement of the COVAX mechanisms. However, the COVAX mechanism, according to a couple of the presentations that we saw, it didn't have the response that we were expecting, at least in Latin America, which probably were the strengths and the weaknesses that our region in Latin America might have had to partially adopt the COVAX mechanisms. Dr. Arrego says. Thank you. Thank you, Gabriel. COVAX mechanism, well, it was not as successful, but it worked quite well. It has been working, it worked for the country. The COVAX mechanism, back in the day, in the moment where the country and from the ministry that we were leading, that decision of the COVAX mechanism was resolving a situation that was very important. And we had all the evidence and everything that we worked with the microclimato model. He was telling us, okay, in order to minimize the risk, you need to invest in a very ample portfolio of vaccination, because at that point we didn't know what worked and what didn't. But from the country, we weren't able to do the same thing as other countries did to buy vaccines from around the world to see which worked. First of all, we didn't have the resources. Then the risks that we as government officials, the risk of our patrimony just putting it behind of that decision could have been very severe. And the COVAX mechanism offered that. COVAX was investing in 13 or 15 different vaccinations at the moment, and they were going to give us from that. So through the COVAX mechanism, we were able to receive vaccinations for 20% of our population, which were essentially those over 60 and people with comorbidities. We will receive them with a small risk that we were giving whatever worked, and it was the supply that we had at that point. But the process of purchasing and delivering of vaccination of COVAX was very slow, but the COVAX mechanism was very much aligned with the needs that the country had back in the day, and it was a good decision back at that point. The other decision was key from the country and our minister is to create contracts and agreements with the pharma companies, because there were a lot of population to cover that the COVAX mechanism was not offering until they supply the demand from other countries. And the strategy that was presented at a point that we saw it helped that the study and the analysis that were conducted by many government entities such as Fernando Ruiz, the Ministry of Finance and Planning. He did a great job by implementing the model of Michael Kremer. A lot of government offices also worked on the decision making, and it worked. We thought that it worked during this, as Ana Maria was showing, the private companies were also jumping in and they applied 1.5 million vaccinations. The thing is that within the framework of the countries, it sounds 1.5 vaccination, it sounds very little, but the application of 1.5 million vaccines is very, very challenging. We're talking about a lot, a very, very high number that against the total it seemed very small, but the COVAX mechanism worked. There is a lot of things to learn from it. It's kind of difficult to handle, difficult to manage contracts. If the contracts of these pharmaceuticals were very difficult to understand, the ones from COVAX were even harder to understand. And the WHO is working towards the future and to make it better. Thank you so much, Leonardo. One of the situations that we were doing in terms of the pandemic was about communication. Communication that we had here in Colombia and in general in Latin America, in the world, the strategies of communication that we were using, the way that our communication, the communication, how we communicated to the population. Dr. Miguel Landi, very, very welcome from Cali. Dr. Miguel Landi just finished her military service, as I say it, as a Secretary of Health in Cali. She was doing everything during the pandemic. What can you tell us about these strategies of communication? How they were able to be more strategic in terms of education and in terms of training, and a little bit less alarming as we were seeing in many other scenarios. Well, hello everyone. Good morning, everyone. Dr. Carrasquilla, it is my pleasure being here in this forum. I guess there's a feedback in the sound. Is it fixed? Okay, perfect. Well, I would like to first talk about the communication strategy and how this have changed and has been transformed the communication and the communication means, of course. Us from public health, unfortunately, we and not only in public health but in science in general. I was reading a couple of books, a book that is called Knowing How to Communicate. It talks about the way that we're scientists, that we create a lot of papers, we contribute for the management of knowledge. There's a lot of communicate. However, we are just publishing in index journals, in journals at an academic level for a specific profile, limiting ourselves the possibility from the public health to communicate those research and to translate them to the general knowledge and the community in general so they could assimilate it and interpret it. We are in the last couple of decades, in the last decade, we are invaded by the digital media, which are a source of information and very little of the knowledge management or by transmitting knowledge. Therefore, I think that us in public health, we need to walk towards that route. They having experts in communication that would allow us transmit the information from the knowledge management by taking a very clear message in our community. One of the main strengths that we had in the ministry, and I can open it, somehow we were pioneers in the communication in traditional media such as television, press, printed press, radio. And we also became a little bit of an influencer from the Ministry of Health with a very clear message, less scientific, that will reach the community. I think that one of the challenges, in spite of us living the pandemic in such a way that we were able to get over them by managing the traditional means, by innovating the digital media, it is still a challenge. not only for possible and future situations, similar situations or pandemics, but also for public health. How we can set it, how we can compete with these networks, with the information, with the level of information that we have, with that mobility and that permanent migration, a very high migration that we have, and high level of management that we have in the different platforms where public health has been lagging because we do not innovate, because we don't do it in the right way. And we think that the information and communication and the message that we send is only for us in the scientific world, when what we actually need is how all of this knowledge can be translated in the right way to our community by using all of these tools that we have and good communicators. Thank you so much. It was very clear. Your answer was very clear for this concern that we had for the whole pandemic. Dr. Daisy Freitas, who was not able to join us because the difference of time difference in Brazil, etc., she gave us a very unsettling presentation in terms of the politicization, how politics interfere in the pandemic, and the lack of political willingness, that we had a lot of government that were determining for the very, very poor results that we had in a lot of our countries, and the lack of, or well, how the politics we had in countries such as Brazil, such as in Mexico, the United States even. Dr. Victor Zamora, in your experience as a ministry, and for the multilateral organizations, which recommendations you can give us for the upcoming events of public health? What are the needs that we have of the strengthening which sectors for those not to be as we saw in this pandemic? Well, thank you very much for your question. I have a couple of reflections. I don't have answers. However, I would like to start from the fundamental fact that the pandemic, among other things, placed in the center, very near, yeah, very center for the healthcare workers, how important politics are. We recognize the link that we have between politics, not policing, politics, the fight of power, decision making, and the impact that it has in our health. And we saw it every day. The fight in terms of not only confrontation of ideas, but also for the positions of power, even economic power, that we had among everyone who was for the decision making, that were not only decisions belonging to the Minister of Health of any of our countries. They didn't involve the presidents, that involved also the legal or the legislation bodies, as well as the mayors and the governors, etc. And not only those stakeholders, we were talking about the fourth branch of government, which is press. We were, of course, within the press and within the world of communications, we have the influencers, right? The ones who take a lot of power in the decision-making process. In order to try to extract lessons about it, Professor, I would like to present a couple of frontiers that we need to explore. One, and we already mentioned that, it was mentioned already by the Cali Ministry of Health, is the management of health, of knowledge. Never before the management of knowledge is a strategic area, not only as I mentioned before, to gather the information, which is brutal in terms of amount and dimensions for the decision making, but also to communicate. How is it that the ministries of health end up using the all tools of the official communication, press conference, against a very savage world of social media? We need to generate new capacities of of management of knowledge, and in the second place, we need to develop on the ministries, on the assistants, a lot of for artificial intelligence. I was mentioning in the hallways that in Peru they've opened the office of Amazon Health, and in the second, what are they going to sell in the future? Since they do not produce data, they compile the data and they sell you aggregated intelligence, which the government didn't have. We need to know how to work with the world of artificial intelligence and also become, well, the capacity doesn't exist, but we also have to see the ways of purchasing and distribution. We also mentioned about the products. How can a government go out to buy a product that is still on the paper and by investing millions and millions on it? That formula was implemented by Chile, but Peru and such as Colombia at that point, we were with our hands tied and we needed to go to the Congress to ask for the change of laws and norms that would allow us to make it quicker, the products of purchasing ideas, of pretty much adventures, that in the case of the pandemic were positive, but in the future it's not going to be the case. And fourth, and I'm sorry if I extend, if I go over a little bit of 2 minutes and 27 seconds, the new model of human resources. And for anyone, it is a secret that we are opening spaces for the training of a specialist in this field with surgeons that would like to do bariatric surgery, dermatologists, but intensivists. It is, as a matter of fact, something that we need to work on it, and that we need to work with doctors and nurses because we don't have enough hands. In Europe, more than 60% of the healthcare workers, particularly professionals on the European healthcare, are 55 years old or older. They have a crisis of resources. How are we resolving it so far? Latin America is a supplier of human resources, and we have without people. We need to take it from here. We need to look for new ways. And at the end of the day, and not less important, just to answer your question, the training on the healthcare personnel on political leadership, how to work in the savage world of politics. One of them is by trying to do by training managers and epidemiologists, but also trying to create the formation of human resources in the private world. But also, we need to form our healthcare professionals to face the difficult work of being the government, and that involves for public policies and pure policy. Thank you very much, Dr. Zamora. I'm going to use a phrase in Dr. Zamora's presentation to introduce the next question. Dr. Zamora was telling us that the primary attention is not the first level of attention. That is super important because facing public health policies that require primary attention with a multisectoral approach. And this pandemic had effects not only for healthcare, but also for employment, the increase of poverty everywhere. They also had, it affected education and how to approach a multisectoral approach, but not only between private and public sector. It is also the participation of the different sectors of the economy, of the government, in a comprehensive, integrated effort for the prevention of new massive events of public health. As you were saying, we were supposed to be waiting for it in future in more than 100 years, but it's going to be there. Since that question is difficult to answer, it goes for two of the participants, Dr. Ana Maria from the private and productive sector and Dr. Francisco Gomez from the educational process since the Santo Domingo Foundation. How can we do the multisectoral pass? Thank you, Dr. Carrasquilla. I guess that it is very trendy to talk about the determining of health. And I said it is trendy because, of course, they are an essential part of the comprehension of that uh, primary attention to health, but very recently, and because the pandemic revealed that the social conditions and demographic conditions had a very high incidence in the response of the populations towards extreme health situations, such as we lived in COVID. But it made it evident that those health interventions are not or cannot be thought isolated as a capacity of deploying an apparatus, in this case, a response for COVID, or that we should talk about another scenario, but they also need that comprehensive overview and for addressing the population. I think that it was very virtuous out of this experience from the private sector point of view is that the entrepreneurs, such as in a system such as the one that we have in the country, the entrepreneurs they need to do a they need to do something with each of the worker. Now we have a healthcare system with a financial protection that fortunately had helped them from the 100 Act, the Act number 100 that goes a little before from the payment of Social Security. But the reality is that we are facing, thanks to COVID, we increase the sensibility of the enormous implication that this state has, or the healthcare status or the health status of the people have with productivity. But the efforts moving forward, they need to be focused. We have very, very specific realities, such as the equal access, but also the essential conditions of the population in terms of food safety, in terms of quality of air, in terms of quality of water that the children are consuming, how many of the things that we have in the country they need to do with the quality of water. There is an actual reality around the aging of the population. There's also reality that has become very relevant in terms of mental health, that are affecting health and affecting on the well-being of the population. I truly believe that the articulated work, and as I was saying a couple of minutes ago, for us, the experience of vaccination simply let us very clear that there is a huge amount of interventions that we can work, not only from the public intersector, to become the right articulation. The problem for this is not only for the Ministry of Health. The problem here is that it goes through the Ministry of Health, the Ministry of Education, the Ministry of Agriculture. So a right cross communication between these healthcare objectives in the public aspect, but also a summoning and a calling and a right articulation with the private sector, because from there we can lead a lot of the initiatives to improve the health condition of the population of the regions and therefore the country. I think that's the direction that we're going to be walking, and I guess that is one of the lessons learned. Thank you very much, Francisco. Well, thank you very much for the question. I think that here it is quite complex what we have in your question, because what we are coming to realize is that we need to work with a systemic approach. Us, from each of our specialties, we were able to be each time more intense in our job, and we're actually going farther and we're becoming specialists. And it is in a situation such as this one that the systemic approach is fundamental. And that clearly has to do with how is it that we map out our system and how we understand the implications of emergency policy that is totally necessary in everything that is happening in the country, of course, from the economic aspect, but also from the economic part, from the educational part, was critical. And it was critical because from the economic trajectory, from different points in that trajectory where we're looking for, we had negative impacts that are directly associated to or with the pandemic. Now, from the development from the infants, from the early childhood up to the socio-emotional development of teenagers and finishing with the quality of education tests, not only in the medium but also in higher education. Not only in medium high but also in higher education. We have teenagers and youths who suffer and that are not in the level that we were expecting. I think that this very possibly was not number one priority due to the context that we are, but I truly believe that it has to do to see which were the other implications in a way that we could prepare ourselves. As of today, we are currently seeing that there's a need of leveling. There's a need of leveling because we had a gap of time of about 2 years where we had we were lagging very clearly, and as everything in this pandemic, this lagging are worse for the more vulnerable populations. So not even in the negative impacts were equal, but the same pandemic is also showing us that our failures become more evident in a moment of crisis. And when we are so unequal in terms of those negative impacts, it is much more important to put an approach in the vulnerable communities, those that didn't have the connectivity that they needed or the equipment that they needed for doing or creating a virtual education that was not prepared in full, and that in many cases it was trying to do in-person education for some means that didn't allow it to be efficient. So I truly believe that there's a calling to do this post-pandemic reading with enough. I mean, we need to be calm enough and intelligent enough and smart enough to understand this relationship between systems. We need to understand that the situation that we live was very complicated, but that it definitely, if this is something that could happen again, we need to do it better. And I truly believe that partly, the educational aspect is fundamental, and also this part of the analysis in terms of the integration of the related systems to it, and of course, to reach that each time more, we become more unequal in our societies in such a way that we don't have those unequal impacts, particularly in the negative aspects of it. Thank you very much, and thank you everyone for your input and your participation and for your comments to these questions that, as you know, we have a lot of things to analyze and a lot of things to develop to know which were our lessons learned and to prepare ourselves for future public health events. As of now, we're going to have a 15-minute break, or how much time? No, less. Yes, yes. Thank you very much for your patience. We're going to do a break, a little adjustment in the agenda so we can keep on time because many of you already have some commitments later on. So we're going to do a 5-minute break for you all to have a coffee. You're going to take your lunchbox at the end, and we're going to join panel one and panel two so we can keep ourselves in the time and we can respect the time of everyone else and your agenda. So if you want, we can have 5 minutes for you to have a coffee, and then please go back. And we're moving on with panel number one and number two. Thank you so much. Hello, good afternoon, everyone. We're back. Well, okay, come on, we're going to start again. All right, we have all of our panelists already joined via Zoom. We're going to start. And due to the discussions that we had this morning, we decided to join panel one and panel two because we already covered most of the topics here. So it is a pleasure, a privilege for me to introduce panel one and panel two in charge of Professors Nubia Velasco and Marta Vives. Half of our panelists are joining us via Zoom, so I'm going to ask our Zoom administrator to please turn the camera on of our virtual panelists. We're going to introduce all of our panelists right now. Welcome, everyone, and thank you all. At the end of the panels, you're going to be able to take your lunchbox that I know that at this time you might be a little bit hungry. Thank you. All right. Well, good morning, everyone. Thank you very much for being with us here. Can you hear me? Can you hear me? Yeah, okay. Good. Yeah, I'm not very much experienced with these technologies, but okay. Thank you very much for being with us here, in spite of the delay that we have in our agenda. So, as Andrea just announced it, we decided to join both panels. In this panel, we're going to be dealing with those experiences that were positive, just in case we're living on a crisis situation such as the one that we lived in 2020. And those situations are actions that we didn't do that we were supposed to be doing and to identify them. So, as of today we have virtually Dr. Alejandro Gomez, who is the the District Ministry of Health, and who faced since the very beginning the crisis for COVID. We have Julio Cesar Castellanos, CEO of the San Ignacio University Hospital. We have Alexander Moscoso, ex-Vice Minister of Public Health and Service Provision of the Ministry of Health in Colombia. Ex-Vice Minister Adriana Roballo, Director of the EEDS Technology Assessment Center. We also have Silvana Zapata. Silvana is she works on the government of Antioquia in the field epidemiology training in the National Healthcare Institution. She's an epidemiologist. Diana Gaviria, Director of Connect Bogota, Region Colombia. We also have Professor Luis Jorge Hernandez, Director of Research of the Administration School, and Germán Escobar, ex-Vice Minister of Public Health and Service Provision of the Ministry of Health. So I yield the floor to Marta. Thank you. Good afternoon, everyone, and thank you, everyone, for joining us today and for participating in this session. We've seen a couple of experiences which have been very, very interesting. Each of them told from the perspective of the stakeholders, and we think that there are a lot of things to save and a lot of things to highlight. And with Nubia, we wanted to direct the following question to the members of our two panels. What did we do well at a national level, at a regional level, at a local level, at a Latin America level? What we missed, what we cannot overlook, because very clearly with the participation of our speakers, we saw that we are talking about traditions and experiences and practices that we cannot leave aside or forget, and also what's missing. Because the reality is that we're going to be facing this sooner or later. We're going to be facing events such as this one, and we need to avoid repeating the same mistakes. So, since we also have a little bit of time constraining, we're going to ask our panelists to be very brief in their responses. So we are able to have the possibility of doing a second round of reactions about the interventions of each of them. So if you want, we can start right now. Who wants to start? Nubia? I think it'll be very important to get to know the opinion of what we did well and that we needs to be kept from the Ministry of Health, Alejandro Gomez, from the Ministry of Health of Bogota. Good afternoon. Good afternoon, doctor. Thank you very much. Okay, to assess what we did right, I guess it's a little bit early to say, but I guess that we just give you a couple of things that I think that we did more or less well. In a minute, I would like to highlight that we need to understand the conditions of the pandemic that we lived in 2020 and how we faced it. Around two main elements. Dr. Gomez, 1 second because we're not hearing you. Can you please help me out with the sound? So, I don't know. Once again, could you please activate your sound? What, can you hear me now? Yes, great. We're back. All right, perfect. So, can you hear me now? Yes, sir, we can hear you. Okay, perfect. So I was saying that we can talk a lot about this, and it is very good that we have this type of spaces. I heard in the morning a couple of interventions, and it was something very called my attention the possibilities of Peru and Brazil. I like the position of our Professor David Valle, that it is a debate that we have with the economists very permanently, but it is very good that we have these spaces so we can put together our experiences. I was saying that I would like to talk about two main things. Number one is a political tension. Stop being so politically correct in this type of academic meetings, and we need to put things on the table. It was a political tension between the two main fundamental factors on the world in 2020 in Colombia, which was the mayor in Bogota and the president of the republic. And we needed to see how what that created and how it was generated. But on the other hand, we also had some issues on the healthcare system. The healthcare system is marked by many things. The history tells us that the insurers don't trust the insured and they both don't trust in the government. So, how can we transform that in respect and a collaboration environment? So, it is a great example that Bogota has to share and we need to study with more depth. But the last thing that I would like to talk about is that we need to make people important. We knew how to solve it in our way. You're going to resolve it from the academia, but we were able to reply to that because there were people on the other side of the line. I see my good friend Alexander Moscoso right there, and I also see Fernando Ruiz, who is a man that I appreciate a lot. We talked in a lot of confusion and a political tension with the COVID manager, Dr. Luis Guillermo. There were a lot of moments that were resolved at last by the people that were working there, by the goodwill of the people that we had at that point. The purpose of moving together a phenomenon that is very, very challenging for everyone. So, a couple of things there could be lessons learned by 2020 and in Bogota without changing a letter to the norm. So, between different actors that were there. Dr. Gomez, we're going to give Silvana Zapata for the delegation of Antioquia with the same question. What they would good and to see what. And I would like to stand out what they do good well. And for the centers, regulation centers of emergency, I guess that they need to improve or creating life. And for this presentation, that the capitals and that allowed, and it is not because we couldn't prepaid it, we need to pay something extra, but everyone was inequality in that sense. I guess that is fundamental. I guess it has been de-escalated. It is a little bit concerning for me because it is has been de-escalated for me. I guess that coordinating the emergency. And I guess that a transformation of the epidemiologists that were not only researchers that were trained in research, they were supposed to go more in the field to live the reality a little bit more. So it's a little bit strengthening, particularly for the higher education institutions, for the epidemiology, and to form them more in the public. Because when you come across with them, they everyone has been working in the public area, and there is a gap that we need to overcome right there, and has to do with training. And I think that we need to keep the collaboration in this and a multidisciplinary sector. I guess that is fundamental. I guess that we have a lot of groups, and exercise of multidisciplinary aspect is very important to keep on strengthening between the academia, the state, and also the people from civil society with experience in other type of pandemics. So I guess that we can keep on doing that. And as Dr. Alejandro was saying, it is a little bit early to have assessed that. It is more in the pandemic. So it is. We need to do a lot of things in this part because we have very, very large challenges, particularly the demographic transition of the country, which actually is going to be complex. Thank you so much, Silvana. Dr. Alexander Moscoso, what can you tell us from your vision and your experience? Good afternoon, everyone. Well, we had the hard work of working with the pandemic directly to do the operational part of it. And I guess that the first thing that we need to understand is that when we talk about the pandemic, we talk about closures. We're talking about UCIs, and we're talking about ICUs and vaccinations, confinements, UCIs, and vaccination. And it turns out that what we did was much more than that, more than confinement, more than ICUs, and more than vaccination. The first thing that we need to remember is that we intervene in determination. We reduced the propagation by the confinement, but also by the epidemiological measures like hand washing, the usage of face masks, social distancing. We created a better new dynamic of life to the Colombians. We issued more than 150 protocols of life for each activity. There was a way of, jumping on a bus, or how to jump out a bus, how to face it. Very, very complex issues. We forgot about the diagnosis led pretty much by the National Institute of Healthcare and how we moved forward. But we stayed in the lab aspect. It was not only from the laboratory aspect, it was not only building a laboratory, but also to determine which tests we used and which we didn't. We were the first country who used antigens in a massive way in the world and created a lot of questions. And we were in a country that who didn't use other type of tests because we didn't have the evidence. In spite of many people in the country use them, all of those determinations are important. All the intervention for treating, which was not only for ICU beds, we led from the public aspect more than 1,000 intervention projects, not only intensive care units, but we also built medium care units. We built up in the hospital beds, and we intervened in more than 500 public urgencies aspects in the country for the unit. And we are talking about more than 150 X-ray equipment in places where they didn't exist for this, that were vital for this process. All of the protocols for managing pathologists, we were trying to adapt the pathologists and the treatment and the places for the special conditions to it. How many attentions, not only by telehealth, but how many in-house visits we did, how many medications we give, how many procedures we learn to do in the houses of the patients. All of the mental health issue, as the Santo Domingo Foundation was telling us, in this initiative, which was part of more than 15 initiatives that were looking for addressing mental health. How we were talking about the electronic aspects or the online aspects, and as Ana Maria was telling us, the problems that we have with oxygen, but also in medication, but also inputs in equipment and biosafety elements. And those were one of the first lessons learned. We need to be more self sufficient. We need to have more capabilities of building the world. I think that one of the things that this pandemic taught us is that the world was not solidary. I guess that solidarity didn't work. In So I guess that we need to work in many things, in many countries, but also in many parts of our country. But we also had challenges. How we were able to open the intensive care unit beds, of course. We were talking about auxiliary doctors and how we achieved in such a short period of time to train, and how the academia behaved in a very good way, trying to find out ways that we didn't have before to train the different professionals that were required for it, all the prevention for vaccination that I'm not going to talk about, all the communication of information of the research and the scientific analysis, such as Alejandro was saying, how we can work together with the whole world. I guess that we didn't be in the public part, the territory, the national investors, builders, everyone working together in a single dynamic. How can we use everything that became available in the world that we had in the country? Remember when we didn't have bioprotection events in the pandemic, how much time it took for us to change technologies, and how we were manufacturing face masks in Atlanta, and how we created N95 in the country, and how we move forward. And not only that, in many, many other things, research and scientific analysis, because we did research in the pandemic. We did a lot of research in the pandemic. We conducted a lot of analysis, how we work in follow up, which is vital. If this pandemic taught us is that we felt united, and when I say we felt united, is that when Bogota needed more beds, in Neiva there was a bed for that patient, and when in Medellin we didn't have beds, we had an airplane to transport patients to Bogota. So I really think that we are working on the comprehension of the economic and social surroundings for the decision making. The decisions were not taken in just a single aspect, they were also taken in different aspects. All the training aspects that never the Ministry of Health ever developed, this rules, all the financial protection system, as you know, no Colombia, maybe the poverty increased due to the pandemic, but not due to the health effects of the pandemic itself. Everything that is to try to work so that what we did was present for it to exist, not for it to be suspended, to lead all those capacities installed, and how to approach a little bit more in terms of territory equality, how we develop better capacities in the territory with the territories with the less capacity, and how are we approaching in that matter, how are we achieving that. I guess that it was a little bit more than use ICUs, more than vaccinations, and more than confinements in a country which is a regional country. I'm gonna show you. I mean, we didn't have a single peak. We have more than 150 peaks because the peaks were regional and the commitments were regional, and we need to see it from that point of view. And I guess that lessons learned is that we need to be prepared. That innovation and development are vital. That knowledge is vital for moving forward and for the country to have better capacities in the future to address this pandemic. And one question that I'm asked every day, what if we did something different? Probably we would have adjusted some things, but I guess that we would have done it the same way with the information that we had for each moment. Thank you so much, Dr. Moscoso. Now we're going to move forward to another question, which is quite interesting as well. What are the actions that are supposed to be included in the national agenda for the future preparation and response for pandemics? And for this question, I'm going to invite, first of all, Dr. Isabel Rodriguez, and then Germán Escobar. Please go ahead, Dr. Rodriguez. Hello, everyone. Well, by considering the limitations of time, I'm going to be focused. I'm going to focus in three specific aspects that are very important for the future. I guess that's the first thing that I would like to mention is that we need to develop formal mechanisms for actually call the academia and the society during emergencies such as this one. During this epidemic, something that was a little bit confusing, particularly at first, was how we were doing the decision making process, who was making the decisions, so which evidence were taken to take those decisions. And this is very counterproductive because it goes against the trustworthiness. You know, who are the advisors? That is very difficult against the trustworthiness for the response. It creates a lot of lack of confidence. So I guess it'll be very, very good to have formal mechanisms to call academia and the society. A very good example that has been criticized a lot, but it works somehow, of some other countries that has done the same thing, is the United Kingdom with the scientific expert groups that they call by the academic, which is a perfectly transparent and known group which gives recommendations, and then the government decides if they take it or not, but they're there. Second is to strengthen the vigilance system, the surveillance system. I guess that the surveillance system in Colombia was very good, but particularly there was a lot of transparency of information, but there were some gaps, particularly in a country with tests are a little bit limited. The number of cases were not enough. We needed more molecular and genomic surveillance. We needed more zero prevalence study in Latin America. We lived in a very different way compared to the rest of the world with faster attack ways. And this is actually something that we see and it has implications for the decision making process. So we need to keep on strengthening the vigilance system so in the future we can make the decisions by our own information and other information taken from other contexts that it is not relevant at a local level. And well, of course, for this, we need more investments in surveillance and more training for our data analysis personnel. There are some initiatives in this field already. And lastly, what we have discussed a little bit is the discussion about sanitary sovereignty at a regional level. Obviously, this is quite complex, and at a short term, it is quite difficult to achieve. It is quite positive that we already have some initiatives, particularly in vaccination, but it is not only in vaccination, but also in other technologies, etc. And even though it is positive that we have initiatives, the key aspect is to guarantee the sustainability of this initiative, and that implies more investment in research and science to create the necessary surroundings for innovation and development so that sovereignty can exist. Dr. Escobar? Thank you. Thank you. Good afternoon. I would like to start that I agree with the doctors. I guess that she mentioned this in a very important way now. The most significant aspects that the country has in the nearby future and in the medium term. I will supplement the intervention with 2 points. Something that we were able to do in a very good way and was detailed by Luis Alexander was to recover a governance that was fragmented previous to the pandemic, which is something that is decentralized and defragmented. That governance in crisis situation and is not only fundamental but necessary. So, what is it that we can do? We need to be prepared to face the crisis with a plan, but not with a manual. We're never going to have a manual, but we need to have a crisis, and we need to be able to take decisions in the right way, in a fast way, decisions with information that many times is not enough. So that's pretty much what crises are about. So in that idea, we need to keep on talking about for the different crises that we're going to be facing, which can be very difficult for natural disasters, chemical agents, biological agents, but we need to have a clear plan of how to face that crisis as a sector and as a society and how to do it in the next way. And in that part, by gathering what Dr. Isabel was telling us, the epidemiological vigilance system has been strengthened during decades, and we need to preserve what we can do in a strategy. We need to preserve those capacities that are installed by Dr. Alexander was telling us. So, and the healthcare personnel that we were able to train so they can strengthen throughout time and they won't get lost through those capacities that we were able to achieve. So it'll be very difficult otherwise, to face a new crisis by rebuilding capacities. So that's it. And I would gather just a little bit of the comments, but it is a vision towards the future with a clear way of crisis. Thank you. I would like to ask the same question to Dr. Julio Cesar Castellanos. As the director of the San Ignacio University Hospital, what we should have implemented in an earlier way or what we cannot stop doing to be prepared. There's something very important that hasn't been commented, but I was actually involved in both groups. But even though there was a healthcare group that was facing the medical aspects to it, there was another group of the government, which was the Accordeon Strategy Committee, which was able to work with the entrepreneurs and the Ministry of Development, where we were designing the going back to the economic activity to the country. It helped a lot because once we connected, you can criticize whatever you want, because talking a posteriori and for everyone who looks at news is very easy, but being sitting there in the working tables taking decisions is very difficult. And I would like to highlight something. National government at any point denied the access to anyone. When they asked us if we recommended someone, so that's why in Bogota and in the country, we actually asked the international experts. At the end of the day, the minister needed to take decisions. And by listening to it and with their experience, they took the best decisions for that method. I guess there were, if we were having some issues, we answered them methodically and with responsibility. I guess that any government, they might think that whenever they're facing an emergency, pretty much since the very beginning of that emergency, they need to create a working group led by their own ministers, but joined by the private sector to prepare going back to normality. That helped a lot because, for example, construction, which is one of the most important activities in the country, because it gives a lot of non-qualified jobs. It creates a very important cycle, a productive cycle, was the ones that started. So when they started, they knew exactly what were the rules that they needed to follow. And we need to preserve it, and we need to take care of it. I'm going to talk about that in another aspect. The survey that you did it, we actually went a little bit more in depth in this topic, but the second aspect, and the other day we met with the academia with a working group that is actually gathering all this information. I keep on asking why we needed to bury, why we couldn't bury the dead bodies as the WHO did it. Why we gave the ashes to the family members and not respecting the rituals of our people. That give us the mental health and let us reminded that it is a serious question. And it is up to which point the transformation of the rituals of the bodies of the pandemic was modified by ignoring the customs and cultures of the society, because that has huge repercussions in the mental health of the people. We say that we are Homo sapiens sapiens, but it thinks that we were not Homo sapiens sapiens, but Homo habilis. We give a lot of weight to the initial control measures, very absurd things throughout the world. The government, we need to release ourselves of the WHO. Alcohol rubbing at the entrance of every places and the mats and everything. I don't think that that works at all. And we actually faced it that it didn't belong and everything, but a lot of people was with an obsessive thing that we didn't think that the measures were, if they were necessary to influence of those who were actually hearing something in a negative way. So in communication, as the Cali secretary was telling us, but we need to think that communication needs to be very, very careful with the mental health of the citizens. And I guess that was something missing a lot. And even though we try to do it, and when the president did it, and that at first had a lot of rating, one of the commitments is that we're not going to tell any lie. It's a tacit commitment. We're going to tell the truth. It doesn't matter if it is hard, but we're going to be taking care of what is being said so we can create more productivity in the people. But none of the productivity sources were such as that one. For example, in the for example, the problem that why they put an empty syringe in a vaccination, all of the workers, a lot of nonsense, that the rest of the world were vaccinated without that. How influence to everyone, for the mental health for everyone, and they were aggressive on the vaccination posts, and for the healthcare workers who needed to deal with that, but it was just one single person. So there's a whole of work there, and I insist that the measures we need to think more in the mental health and not to do anything that is strictly proven to be the protector of the health, because they contribute. Of course, it's not only that. I can actually go further in mental health topics, but that's the main topic. Thank you very much, Dr. Castellanos. Now, following with the question of what should be included in the national agenda for the future, we would like you to please share your Dr. Diana Gaviria and then Dr. Adriana Robacho, so we can share with us. Thank you very much, Marta, for the invitation. I'm very pleased to be here. I'm not an expert on health, but I hear very attentively everything that has been discussed. And first, it was a very unexpected pandemic, and in the middle of everything, Colombia did whatever they want to organize themselves and to have relatively positive results. I would like to talk to you a little bit more about the role of social organizations and particularly the entrepreneur community in this process. Conet Bogota Region is a nonprofit organization led by 24 universities and 35 companies who foster entrepreneurship and innovation in our region in Colombia. As a matter of fact, the Father Pelaez is the president of the board. And when the pandemic arrived, it was very impressive to see how the group of entrepreneurs, of social entrepreneurs, academics, clinics, and entrepreneurs of scientific and technological basis, they got united not only with the universities to work with, for example, the issue of the ventilators, but many other medical devices that could contribute. But they also worked to see how very, very swiftly they could change or give solutions towards health, particularly in the digital aspect, so we can better deal with the patients and to contribute in a better way with the solutions, even with logistical aspects to it. Attention, primary attention. And in that sense, I would like to talk to you a little bit about an initiative that we developed with the University of Los Andes, with Impulsa, with financed by Sura and Roche back in the day, which was to give a very quick call to understand which solutions we were having from the academia and from the entrepreneurs, from the monitoring aspect and prevention aspect of COVID. And it was amazing how the academia got together and entrepreneurs got together to assess those proposals and to select the best ones and to give the better follow up, giving very fast solutions. And maybe what they want to emphasize is that in the following situation, that it is very important for the government and the healthcare sector would manifest very quickly how we can support each them, because many times we feel that we probably would have done something more or much more and we were not able to do it because we didn't understand in the right way how we could contribute. And on the other hand, I guess that on the protocols that were developed in the future or that are supposed to be followed in the future, it is quite important to see how both the government and the healthcare system could take advantage of these capacities of the academia and the entrepreneurs and social sectors in a more efficient way. I guess that's pretty much what I can say from a different optic. But I don't know if you know the initiative Colombia Cuida Colombia. It was quite impressive, and I guess that there were many, many more that if they were very well articulated, they probably would have more impact. Thank you, Diana. Dr. Adriana. I have many things to reflect from there. I guess that we need to see that there is a very important capacity and a lot of solidarity, even though it was not international, but it happened in our country, and that is due to our region. Our region has very similar needs. Our language unites us, the situation unites us, and we realize that everyone is doing the same thing. But nobody expected to have more results. I guess that it is quite important as well that the ecosystem is complete. According to what Dr. Diana is talking about, we need a lot of opportunities to cooperate, and if we did it in a more organic way, we probably would have had better results in the future. But we know that there are capacities. Capacities were discovered. Capacities coming from the academia, from the institute, from the IS, from the National Institute. A lot of people that is very capable. We didn't have the opportunity, and a lot of people were deployed as they could. The topic of decision-based evidence-based decisions. I know that it is not very easy, but all the decisions that are supported with evidence, it makes it easier for the decision maker to decide something else when they decided about lives and to decide if one thing can change or not. Leonardo mentioned this before, what type of vaccinations we needed to purchase, which was the optimal portfolio of vaccination. We also worked with Marta at some point if we did some antigens or antibodies because we had a lot of money that we needed to invest, but the decision if we needed to decide, we probably would have give a lot of risk to a huge population. So I guess that it is very clear that the country has capabilities. The country is good. People are good with people. And that social tissue is very important. I don't think that every country has it. I, for example, was thinking how old people was dying in Europe in homes, in the elderly homes. That didn't happen here. People take care of their own people a lot. And the other thing, I was in a lot of the committees. I was in the committees of vaccination, in the cabinet at a national level, and the decisions were actually the best, with the best intentions possible, by supporting what Dr. Castellanos is telling by informing of what they have. But we also then realized that we're not doing more because a lot of the decisions were taken very early in other countries throughout the continent. In many months, in many decisions, we actually move before PAHO and even the World Health Organization. There are things that are capacities that we have them. We need to make it better. We cannot get rid of them. It was quite interesting to see the digital aspect. Everyone was creating models. A lot of people doing models is something that we can do, but we can do it in a better way, in a more coordinated way. I guess that we had a lot of good intentions. We have good people. We have good professionals. People is trusting everyone, and but this is very valid. And I guess that many people here, how can we do it with the vaccination? How can we do it? And with all the capabilities that we were able to do it. So it is quite, we're feeling proud about this solidarity. The country based on the resources. We gave everything we did, Minister, Mr. Vice Minister, and Dr. Ospina, and I'm the witness of it. But I'm very proud to be able to participate and to have everyone so good. Thank you very much, Professor. Thank you, Dr. Adriana. I guess that pride is expressed, and I share that. I feel very proud of how the country answered against the situation. Now, I would like to ask the last question to Dr. Luis Jorge, who was very critical in some of the actions that we adopted from the government. We would like to know today, and you know, after the pandemic and seeing the actions that we're taking, what are the post-pandemic actions that we needed to take? Because the pandemic is not over yet, because we're in a post-pandemic period that we need to keep on being prepared. Yes, thank you, Professor Nubia and Professor Andrea. to value a posteriori. It seems very, very easy from this period, but I would like to say a couple of things. What could be changed? What could have been done? I guess that the World Health Organization delayed a little bit in give the importance of the masks. I guess that it got a little bit late on giving the importance to ventilation. We were pretty much focused on the asepsis and antisepsis part. Everybody's cleaning, cleaning everything using ultraviolet arcs. It created panic. It didn't give the importance that aerosols did at first, ventilating spaces. I guess it was very difficult for everyone at an international level. And I truly believe that countries opted for, and that is something that we need to look for. There were a very, very large response strategy. We were talking about Dr. Moscoso, and mitigate or eliminate the countries. The countries opted for a mitigation strategy to avoid the healthcare services to collapse. I guess the elimination of transmission, which for me has been a little bit stronger. The strategy of elimination of transmission would have implied that tracing and isolation would have worked fully, but it didn't. It didn't. To do it intelligently, to dar Bogota, to report everything, it didn't work in full. And sometimes we chose easiest strategies, quote unquote, like, for example, doing confinements or locking people, close Kennedy and to close the city of Medellin, for instance. So it was this very, very hard strategy to follow. I would like to highlight as well that we have a installed capacity. We were mentioning with the lab and with the National Institute of Health. This is very important. Us as students, every week we look at the epidemiological bulletins, and these are updated. Like Marta Espino, Joaquin Prieto, they're updated on the week 40, 44 in the pandemic. We had the permanent information. The dashboard that Dr. Moscoso was working on. It was something very, very important, and that helped a lot. And I would like to highlight that. Do not lose the sentinel surveillance. We need more anticipation. It is something that we're doing something wonderful. We need to reinforce that. This morning we were showing, Ana Maria Arandi was showing us that from a lab, we moved to 24, to a lot of more. By count, they have a lab. Guajiro doesn't have that lab. Now we have that capacity, and that cannot go back. The thing is that we already went through a pandemic. In 2009, 2010, we had a pandemic of influenza, and the pandemic of influenza left Bogota with 6 sentinel unit in that part. The, the COVID pandemic was received with only 2 sentinel surveillance. We need to train more talent in epidemiology. We need to, our vice dean was telling us that we need to have that dichotomy between the public and the private. We're having a public function. The pandemic was the opportunity to show how potentially the public and the private that health is a public function, how to do surveillance and how to do a more anticipation monitoring. And it also taught us to have a better risk management, not based on fear. And I guess that the role that Dr. Moscoso did and the minister, a lot of people in the ministry, but of not showing the fear with messages, but it cannot be based on fear and social risk. We used war mechanisms. Curfews are mechanisms, and that affected a lot. Thinking of not having fake dichotomies in health between individual and collective, between the economic and health as well. If the economic is part of health, this morning they were saying that the impact of the confinements is still being felt, and we're going to have a lot of years among us. Finally, one lesson learned is to create more technological development. As Dr. Roballo was telling us this. We need to develop vaccines to become part of production of the production chain, and that's teaching us and the government that we are recurring with that information, and we shouldn't go back in those progress that the institute has. Don't need to go back. That is very important. And the academia needs to be As Alejandro Gaviria is saying, it's a counterpower, and academia has a very important social function. Thank you so much. Thank you, Luis Jorge. Well, with this, we finished this. We couldn't do a Q&A round, but I guess that everyone has a great overview of it. Thank you, everyone, for those participating here because you did a very, very balanced evaluation of what we can do, what we cannot lose. It is very clear that the capacity of the people, of professionals, of the people that we work every day is one of the most important things and the more valuable things, but there are some things missing to formalize the links that we need to establish between the different sectors. So all of the efforts and all of those capacities, as a matter of fact, could be empowered. And on the other hand, and many of you have mentioned it, health sovereignty. We need to have a regional capacity, national capacity, maybe subnational capacity, maybe at a Latin America level to do agreements in the region that would allow us that independence. Thank you so much. And then we move forward to the next panel. Please, a big round of applause to the participants. Well, thank you very much. We're going to start with the last panel of our day to close our session of today. I'm going to invite Mauricio Serpa Calderon, Dr. Marta Lucia Ospina, Dr. Leonardo Arrebocés, Dr. Gabriel Carrasquilla, and Dr. Fabian Andres Rosas, please, to join us. This number three panel is going to be about the contributions of Colombia in the future of the health in the Americas. Thank you so much, everyone. Well, thank you very much. We're going to start with this last panel. Thank you for staying up to this hour, and I'm so sorry for being a little bit behind in time. Well, I'm going to introduce myself. My name is Rashid Lachas. I'm the professor of economy in the Los Andes University. I've been the scientific university with Covida, working with Andrea and the rest of the team here. So, I want to introduce the guests. Mauricio Serpa Calderon, International Advisor for Emergencies in Health from the PAHO, from the Pan American Association of Health. Leonardo Arregocés, Consultant of the World Bank in the United States. Gabriel Garrasquilla, Vice President of the National Academy of Medicine in Colombia. Fabian Rosas, President of the Association of Colombian Specialists in Urgency and Emergency in Colombia, and Marta Lucia Espina, Director of the National Healthcare Institute. As we can see, we have the great honor to receive people who have been and that are part and are in front for both in the decision making and the analysis and the academic analysis of my understanding what is happening and to try to look for this topic. So, in order to share our opinions, we're going to have this question by considering the national experience and the neighboring countries in the America. What is more necessary, the leadership of Colombia to contribute to the future of the health in the Americas and towards the end of the pandemic of COVID-19? So if you want, maybe we can start from one side of the table to the other. Who wants to start? Great, let's start with you. Oh, okay, perfect. Very good. Well, good afternoon. Colombia has the possibility of playing a very important role in the post-pandemic. As a matter of fact, we've been doing it. And in order to explain it in a better way and not to take a lot of time, I'm going to be using a structure that I think is very practical. In 2019, before the pandemic started, we were showing that all of the countries and among the countries, all the departments and municipalities needed to have basic capacities of surveillance and response. We were doing emphasis with this. We were talking about vigilance or surveillance model based on early alerts, and we thought that at that point that was the way to identify that is an emergency. The pandemic left a lot of lessons learned that leave the answers to the questions that we're doing in this panel, and this are absolutely clear that we've been discussing with many other countries. We've discussed it in many other institutes in Panama, in Buenos Aires, in Cuernavaca, where we're talking about this exactly. So I'm going to say what it is. In the world that we perceived that healthcare surveillance was the port of entry for the detection of the events, it was very clear to us that it was not as such. We thought that the surveillance systems are late systems by definition, and COVID 19, after showing that we had cases outside China by December 2019. So we have some genomic data. It demonstrated that yes, if the first line was the clinics and hospitals, if all the clinics and hospitals committed themselves and warranted that it is a theological diagnosis and not a syndrome diagnosis of the events that they had, and they make sure that we had a final diagnosis. In that way, we don't have those events without diagnosis that normally happens. You know that it is very common, and you know there are some codes that are X's, and you know it doesn't work for us anymore with such an emergency event. So the first lessons, the X codes need to disappear. Only chronic diseases they can stay. I wanted to fine tune the diagnosis in hospital clinics, including the metagenomics, so we wouldn't have diagnosis there without etiology, and that would allow us to early identify emergency events. Another job, the laboratory is the protagonist of this show, and it can monitor what happens to the population. But how? By evolving by having probabilistic samples in their territory. We actually did with genomics, and Isabel, let me correct them, that Colombia has one of the better genomic aspects in Latin America, and we can show it right now. So by having probabilistic samples in the territory, we can actually know what's going on and how much and what's the weight of that. So the evolution of the lab of that passive aspect to receive this for doing powerful statistic analysis. Now, for the capacity, and there is no way back. All of the diagnoses that are non-molecular are sent. The liquid biopsies are the future. We're thinking about cultures, but we need to have our incubators kept. And the laboratory evolves, and the APS is more present than ever. The diagnosis and molecular diagnosis, they need to be at the service of the community with different areas. Now, in terms of the management of lymphedemia, it is very absurd to think that we can have a spokesperson and press bulletin, and for that, we're talking about the handling of opinion agents, and that is a very different approach to manage the risks. And of course, open sources, because at the end of the day, everyone has a capacity of analyze and they have the desire. And the desire without doing the statistical analysis, it becomes the information chaos that we all are living. So, out of that, that is very quickly what we're doing. Those are the changes that every country needs to do. Is a logical evolve. And with representation, something that Silvana said is that, for instance, we have control towers. An example of a control tower is when we manage the immediate response aspects or the usage, the centralized usage of ambulances and the centralized manage of the intensive care beds. That should arrive for not going back. And in that way, we can have a more efficient distribution of the resources of a country such as Colombia. Thank you so much. So we follow with the same order, Mauricio Cepa Calderon. Yes, thank you so much. Good morning, everyone. About my participation, I wanted to base that a little bit in these five strategic lines that in the 30th Sanitary Conference held in September this year, when a lot of people participated, we didn't do a lot of lessons learned, but yes, in very different countries in the Americas for the progress made and within those lines, which are our weaknesses. I guess there are a couple of points that we can underline the role of Colombia first as a very important axis is to strengthen the leadership and governance of the countries in this type of emergencies. I guess that in Colombia, we saw that initiative through the good awards from the presidency and how the need goes beyond the healthcare sector. I'm very well associated with the health determining issues. Something very important is to the decision making, for instance, on the non pharmacological measures based on evidence that many of you had mentioned it. But it is true that at the evidence gets a little bit gets here a little bit behind. And what can happen in the countries in the Americas that governance in many of the countries give us a lot of inequalities. And if that governance is very strong at a national level, it is very weak in many territories in our countries. The second point that I've mentioned is all the strengthening on the information systems and the vigilance epidemiological systems. I guess that Dr. Marta already talked a lot about it, but I would like to mention a couple of them. For instance, because of course there is an issue of budget and capacities, and in this case, the regional networks have been very useful to keep on strengthening, for instance, this regional network of genomic surveillance, COVIGEN, that, since Colombia's capacities, for instance, yesterday we were with the INS opening, and there were 7 countries in the region with lower capacities, with lesser capacities that are this week, and the INS is strengthening their capacities and genomic capabilities. That spirit towards moving to equality is very good. Or maybe mentioning that great expertise that Colombia has on the field epidemiology programs and FTP programs, where we will have a lot of things to contribute. Now, the third axis on the strengthening of the healthcare systems and the networks of service provision, it is good. It is true that together the countries in the Americas increased 113% of the UCI beds, but it is also true that it was made, by sacrificing the essential services in health. Primary care at a regional level, it dropped to 53%, elective surgeries to up to 60%, and rehabilitation to 52%, and many other information. So how can we work for the countries in a new emergency, because it's going to come over, how we can give a better response to it, but without weakening those essential services that we have in our population. Another important point that we need to mention, human resources, that stability that we need to give to our doctors, and mental health. That is very, very clear. You mentioned that a lot. I'm not going to go very much in depth to that, but something very important here that we mentioned is the scientific evidence. We've been taking a lot of measure based on infodemia and fake news, and we needed to actually wait for the evidence for, particularly for those pharmacological treatments. Fourth is the strengthening of this response of emergency and that supply chain. We saw at that point, particularly in the Americas, since it was a global emergency, we had those difficulties to buy personal protection equipment, medications, etc. So in that sense, yes, there was. We're talking about that independence at a regional level, at a national level, and I guess that Colombia has full capacities to bet on that production of drugs, labs, lab materials, laboratory testing, and vaccinations to do it, and not only for the benefit of Colombia, but also for Latin America. And the last part was the introduction of vaccinations for the vaccination programs for both COVID and routine program, in which I guess that we made a lot of progress. We need to mention, for instance, the role of the rotatory role of the PAHO. If every country goes together, we can get a better price for all the populations. And I guess that those type of activities need to be kept on going. And I guess that Colombia is one of the main players in those initiatives. That's it. Thank you. Excellent. Thank you so much, Leonardo Resgoses. Thank you. I'm going to talk about 3 points that I'm going to summarize them from Colombia. How Colombia can lead the region with this. Number one, governance. What I think that it was very clear for us here and made us see, and we understood, yes, we can have an structure of governance that would take our decisions to benefit the people. Colombia did good, and it was a great leadership in how that governance should work, and particularly there are two aspects that Colombia can help us out with this. Number one, everything that has to do with the epidemiological vigilance in the National Institute of Healthcare. It clearly has a lot of leadership and it achieved a lot of leaderships and epidemiology vigilance that we can share with that and in the region. Martha has participated with everything that has to do with surveillance in the last 6 or 7 years. She knows this topic very well. And there is a great knowledge that we can take advantage of from someone that in Colombia was from here. Let's see with this new institute how it does it. And the other thing that Colombia was leading that we were talking before is that has everything to do with the independence in the production of doing this response. One of the key aspects is the production of vaccines. It is not strange for us that we should be aware that the next emergency is somewhere where the vaccines are going to play a very important role. And from Colombia, from the mechanism of Prosur, is encouraging a work of what are the capacities that the region has to produce the vaccines, and which are the recommendations that we did for these countries, for this recommendation, and all the Prosur countries are there, and all of the countries are saying, okay, I'm interested. Even Paraguay, who is a small country, they say, okay, I want to produce with the advantage that Paraguay, when, at being small, if they create, if they achieve production capacity, they become an insurance to the city. India is a great production of vaccines, but they close their borders, but you need to produce their 1,500 people. Paraguay has a great capacity of production. They would allow this, and everything that is left is for the region. Colombia has been playing a leadership on the region, how with the production of vaccines. And then we have the governance and how these medications work. This becomes very important, and how Colombia is showing something very important, and it is something very important in the articulation between the government, the academia. The academia is where the knowledge is generated. So the government, the academia, they need to work together. There are some spaces that we achieved it and some others that we couldn't, but it's this pandemic, we can do it. And as Isabel was doing, it is these mechanisms for bringing the academia to work on it. They need to be clear, they need to be expedited. We need to know where the money is coming from, how we're going to do it. And, you know, for the participation. So not all the academic can be brought because it becomes a very difficult dialogue to handle with. And since they invited me, I need to work on that. The private sector is very important. As Ana Maria was showing us, the private sector has great incentives, has great intentions. One of the most important topics of the pandemic, and how many times with the private company we can see in the public and private, and in the private aspect, it says the private sector is taking from us. And the important part is that we have a couple of steps, and the civil society, how civil society becomes more participant. And in Colombia, we have this. For example, this forum is a clear evidence of this That is a civil society that we have the Foundation Santo Domingo here, and to be able to discuss and to learn about these topics. Colombia, learn how to do it, and how can we compare ourselves with Peru and with Ecuador with very different experiences, how we can do it. And for this work, it has been very important for the civil society. And something that is behind it is that Colombia can actually pull and have played a very important role for the convergence of of this regulation. And as of today, a lot of things is happening. For example, the supply of medications, vaccinations, which is very difficult because the sanitary norms have been used as of mechanisms. So the mechanisms, for example, the drugs that are produced in Ecuador cannot arrive to this country because they saturate the market, and we're using different things to resolve trade issues. And even though we reached the emergency and that didn't work for us to respond, we can work a lot to have a great supply. And as Dr. Boscoso was telling us, the pandemic is not only on a single peak, but they appear in regions. And if you have a regional capacity of response, all of those inputs can move around to the sites where the emergency is actually happening. But for that, we need to have a convergence of regulation for everyone to understand the same thing. And Colombia has been trying to have a great leadership in this. It hasn't been very easy, but for the emergency, we need a regulation that would allow us to have a better response. Next point, diffusion of learning. This colloquium and other works that have been moving ahead for lessons learned, these are going to be very important for us in the future. Colombia has a great leadership, and as everybody was saying, Colombia is one of the countries here within Latin America of those with capacities. And Colombia has a leadership, and they recognize it. Now, we need to make sure that towards the future we cannot take decisions that are affecting the countries that we have. They had a very interesting option of this agenda to pull it from the Pan American Health Organization and a decision of pulling support because they do understand that this were not aligned with the ideology of this new government, and they removed the support. And with that, I guess that's going to affect not only Colombia, but the other countries of the region. Colombia has a very important role with a great experience that we can share, and hopefully what we can get from this colloquium is something that we can share and share with the world what we did good, what we didn't, and so we can be able to share and then we can use it. Excellent, thank you so much. We're going to yield the floor to Dr. Gabriel Carrasquilla. Well, thank you. When you're the previous to last, there's not much left to say, and you have the risk of repeating everything, and that's going to happen right now. I'm going to repeat about how the country and how Colombia are with the experience, how we can contribute with the region. I guess that it's been quite a bit, but I would like to repeat this. World Bank and the ministry, they developed an analysis about lessons learned, about processes of the pandemic, and they touched pretty much four large areas. Number one, governance and public health. The other one, the development of information systems. The other one is capacities for the acquisition and distribution of resources. And the last one, the approach, a more macro approach of social determinations. And they were qualified quantitatively. And out of those four domains, the best one on that effort that we did in that project, the best one for the experience of Colombia was governance, governance in public health. The top of the score that was established was 4, and for governance was for 3.5. There were other areas with a lower score, but this is just to highlight what has been repeated, that governance was something extremely important. Second, that I think it is quite important is the surveillance part and how to work for the genomic vigilance. This has been told a lot, but I would like to just say something extra. The National Medicine Academy grants an annual award for research in Colombia, and it is received with different applications. This year, the National Award of Medicine was actually obtained by the National Institute of Health, and Dr. Marta received the award 18 days ago, actually, for the genomic surveillance of the pandemic, to be able to define that was universally accepted as a contribution by Colombia. That is something else that we can actually contribute. Now, third, that is something very important, is Dr. Silvia, the project of the Los Andes University, the collect project that has been developed by the university, has a very important contribution. One that was asking me for social media was very interesting because we did some follow up in social media when we had fake news and some issues that were altering the information in the right way, and we did a right follow up. And I'm going to move forward to the fourth point, the last point, because I see a lot of people with hypoglycemia, even the people virtually. And the thing is that, yes, we considered the scientific evidence, we considered the available information, but that is not only just spontaneously, that is not for free. I guess that a contribution by Colombia is that healthcare cannot be a political trench. We had the advantages that the people that were in charge of public health during this pandemic, at the right, at the left, the Minister of Health, they all have a very high academic training, a PhD level, and that of course definitely works for that hunger of clear and timely and scientific information for the decision making is great. And it could be achieved, and that's why the pandemic in Colombia had better results compared to other countries because of that. I actually conversed with both of them, and they were always willing to the new evidence. Leonardo formed a group of female epidemiologists. It was spectacular. They were always joining us and exclusively on the bibliography that was mentioned and were distributed with the decision-making group. And it was translated because Minister of General Director, they have no right to read the science or nature, but it was translated and it was contributed for the information to be permanent, updated for the decision making. Thank you so much, Doctor. And now, Dr. Fabian Rosas. Well, good afternoon. I'm going to be very succinct. I'm going with the idea of Dr. Mancilla for hypoglycemic. I'm going to give you a kind of a different point of view. I have a different overview, a more specific, a microscopic lenses in the sense that I was in the first line, in the attention. And I'm going to take advantage of this space to congratulate everyone from our team, doctors, nurses, therapists, security guards, everyone, paramedics, everyone who participated in the first line of attention. But then you look something and then you see what's behind it. So in this attention, sometimes people say, okay, what happens with the line of oxygen? And to understand Ingrid and to be able to articulate, and for those multi-sector scenarios that we did before, that we didn't do before, and how in the operational aspect on it, Colombia was the leader, and how we articulate the financial aspect, the political aspect to create some actions in pro of all the communities. And I know that because we were able to create teams and working teams, multinational working teams, when we can share emergencies with first responders with many countries. And Colombia is always saying, okay, yeah, but how you were able to solve the oxygen crisis, for instance? Well, we call the producers, we call the ones who do it, and I guess this was an idea that was able to be replicated in Latin America and that from the multi-sector aspect, and I guess that's something that we cannot lose, that needs to endure not only for future emergencies, not only for future pandemics, not only for the attention in healthcare, but also for the attention of emergency in the other sectors from the point of view of the financial aspect and healthcare. I guess that we can contribute a lot, and I guess that is one of the main ideas and scenarios that we cannot lose sight of. The other point of view is within the sector, the healthcare sector, how we were able to unite more than 130 unions of health led by the Colombian Association of Scientific Societies. And in one hand, with an academic arm, they were able to connect with everyone and they were able to create the guidelines with the leadership and with the Colombian Association of Infectology. But we will also see a lot of them where we generated a lot of recommendations based on evidence and evidence brought from being able to sit down with experts from Italy, from Asia, from Spain. You had the first wave and the second wave. What can we expect? What were your experiences, and what can we learn from it? And thanks to that, we were able to create a lot of recommendations, not only for the units, but also for hospitals or rural hospital centers that had no idea how to act with a huge demand of patients who were in an emergency or in an earthquake. We use orthopedics, surgery, but it is something vital, such as oxygen, how we can manage and we can generate those attention processes based on that. That's what we did. We got together internal medicine, anesthesia, emergencies, and we were able to create a lot of recommendations not only for the large cities but also to the rural sector. So I guess that one of the lessons learned and responding to the question that you have and being a little bit more succinct, Colombia leads and needs to keep on leading and needs to support and encourage multiple sectors to be able to create processes for the attention of patients. I guess that to being very concise, I guess this is the main purpose, and we cannot lose sight of it. Thank you so much. Marta Lucia, you wanted to say something? Yes, 1 minute. I'm sorry. From what I said, something very important that we consider as institutes, the model of response in emergency of public health in Colombia is very good. We say that we're the big brother and has 5 arms and needs to be the standard. And I guess that's a great contribution for the region and for the world. And it's surveillance, research, modeling, mathematic modeling, information with open data, and communication in social media. Those 5 pillars are simultaneous, even with epidemiologists, my colleagues who think that research cannot be done in emergency times emergency. But yes, I mean we know that we do, And those five arms are the contribution, and they are those are being acquired by the other institutes. Okay, finally, I would like to send out something that is very common. We're not going to have a time for a second round, but we thank you very much. Something in common that shows this event, both the speeches for all of the guests. Colombia is a very technocratic society, in the positive way of the interaction between. There's an interaction between academia and the government, which is very strong. I've been working in the U.S., in France, in Mozambique, in many continents, and I've seen in any countries such a strong connection between the academic world with, without the monopoly of their knowledge and the governments and the decision making. They don't always do what the academic do, and they shouldn't because they have other restrictions and other things they need to consider, and not even the academics are going to be in agreement with them. So that's why this knowledge is keep moving, and this connection has been very strong, and I guess it is a source of hope to keep on going and to keep on building more in that direction. Thank you so much. And our vice dean wanted to say a message. Yes, to finish this, because yes, you're gonna faint, Dr. Carrasquilla. We don't have enough doctors here. No, I wanted to say a couple of things. First of all, I would like to congratulate the members of COVIDA because they received the award of research based in, evidence in Colombia, who are part of COVIDA. I was actually part of coordinating COVIDA in the second part, but I would like to end this by paying homage to a person who is here, a personal and institutional homage to a person who led the pandemic, who didn't care that we were public, private, but then we can all get together. I don't remember, Marta, what's the number of labs that we used to have that of the network that you created, but if something that we learn from this epidemic is capabilities in labs. We have people here, Marcela Guevara, who works in the laboratory of university, and I would like to take a couple of seconds to give a big round of applause to this person who leaves the National Healthcare Institute and that leaves us a lot of things. Well, with that, we finished. Thank you, everyone, for everyone who is connected. I don't see how many we had, but we had some pics of 100 and something people connected. We're not going to do anything hybrid, so you can come here in Andes so you can feel the cold that we feel here. So thank you, everyone. Thank you, all of our guests who came over from several countries. And when you have your lunchbox at the end, and that's it. Thank you so much.